much. It's okay, I'm only given one minute. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to SAPH 2026. It has been our tradition to start the workshops the main sessions. And it meant to be for our junior colleagues, and also has been a tradition to start with radiology, right heart catheterization, and risk stratification workshops. So it meant to be for colleagues who have been interested and recently joining the treatment of pulmonary hypertension or in the training programs. It is, I know it's a bit early, but many people are on arrival, but we have to start on time. We have a very good number of registration online. This is a live broadcast also by Facebook, YouTube, and all the social platforms. So it is my pleasure to introduce my colleague, Dr. Sarah Rashid, who is a pulmonologist and interested in pulmonary hypertension. She's from King Faisal Specialist Hospital in Medina. And she will be moderating the first session, and the first session will be conducted by our colleague, Dr. Manahi ibn Saidan. He's a consultant radiologist at King Faisal Specialist Hospital, who is also interested in pulmonary hypertension, and he's a great help of ours in the PH program at King Faisal for diagnosing patients with pulmonary hypertension, particularly SAPH. He will go over the pulmonary hypertension findings and many other aspects of radiological aspects of this particular disease in a workshop manner or format. It has to be somehow interactive, and it, as I said earlier, it is meant to be for our junior colleagues, but thank you all for attending.
Good afternoon, everyone. I would like to thank you all for attending our pre-conference workshop today. First, I would like to thank the organizing committee and the chairman of the SAPH, Prof. Dal'an, for inviting me today. It's really an honor and a pleasure for me to be part of this amazing SAPH. Without further ado, I would like to give the mic for our colleague, Dr. Manahi ibn Saidan, to start his session. So he basically talking about the comprehensive multimodality imaging finding in the pulmonary hypertension and specifically in SAPH. So please, Dr. ibn Saidan, mark is yours.
Assalamu alaikum. Thank you very much for having me. Just a quick question. Do we have fellows, trainees? Okay, excellent. So this is going to be mostly interactive. I know it's a multimodality findings, but mainly we rely heavily on CT. So I just renamed it the CT detectives. Just a quick review of the pulmonary hypertension groups. Group number one is pulmonary hypertension, which is the most common one is idiopathic. But under group one, we have different classes. So one of them is CTD without ILD. If we have CTD with ILD, it's going to be group number 3. Also, congenital heart disease and the interesting entity, PVOD and PCH. Okay. Then group 2 is going to be left heart disease. Group 3 is going to be lung disease, mainly COPD, ILD. Group 4 is my area of interest also is CTEPH. CT plays a significant role in diagnosing and also guiding management. And group 5, which is miscellaneous, including systemic disease, sarcoidosis, LAM, LCH. So X-ray is available, but it's not actually very helpful. VQ scan is very, very helpful in CTEPH. Suspecting CTEPH, VQ is abnormal, ventilation normal. Perfusion, we see multiple peripheral defects, then this is CTEPH. But can we tell from VQ, is it acute or chronic? No, we need either one. We have baseline to compare with or CT to assess the pulmonary arteries. Okay? Then the CT. CT is very good in even suspecting hypertension. It's very good for assessing lungs, cardiac, vascular, mediastinum, extracardiac findings. 2 limitations, hemodynamic assessment and peripheral disease in CTEPH. Okay? If you want to do dual energy CT, we'll have more advantage. So dual CT energy, we'll do it in 2 different energy levels, and they will create the iodine map. It's going to look like something like VQ. You will see the perfusion. Combining it with the CT assessment for the chronic PEs, it has very high sensitivity and specificity for detecting CTEPH. MR is good for assessing shunting, RV volume, and function. Okay? So for the juniors, the whole lecture in these 2 tables. Okay? Then it's going to be interactive afterward. So assessing the mediastinum, look, first we start with the pulmonary artery, and I'm putting question mark, 29 millimeter question mark. Okay? And I will come back to this one. The more useful one is the ratio of the pulmonary artery to the aortic, to ascending aorta. If it's more than 1, then you should suspect pulmonary hypertension. The other findings like filling defects, obstruction, calcifications, peripheral tapering, and pruning. Assessing the RV size on CT is very challenging, okay? But if you see the RV to LV ratio is more than 1, then you know it's enlarged. If the septum is flat or bulging toward left ventricle, you know there is something in the RV. And the RV normally, especially the RV free wall, is very thin. If the wall thickness approaching 4, then we should suspect RV thickening or hypertrophy indicating chronicity. Then we go down to the septum looking for AST, VST, left side bulge because of the increased pressure. Then we look for the aorta generally as our approach. We are looking for PDAs. Also, we are looking for bronchial and non-bronchial systemic collaterals, especially in CTEPH patient. Okay? Then we assess the pulmonary veins to assess for any anomalous return. Left heart, left atrium is very useful. If it's enlarged, suspect something wrong in the left side, either it's myocardium or the valves. Then the pericardium effusion. If we see pericardial effusion and I am suspecting BVOD, BCH, then it's going to support my suspicion. But also you see it in CTD, we see it in severe or long-standing hypertension, or even CTEPH cases, you can see small effusion. Lymph node enlargement. Again, if I'm suspecting BVOD and I see lymph node enlargement, this will support my suspicion. But you can see it in sarcoidosis, reactive lymph node enlargement in CTD. Okay, now we go to the lung findings in different groups of pulmonary hypertension. The most useful one is normal. If you see patient does not have pulmonary hypertension, lungs are normal, this is idiopathic, group 1 idiopathic, the most common one. Okay? It's going to start being confusing if you see ground glass changes. Okay? When you see diffuse centrilobular or lobular ground glass, in patient who's group 1, then the question is it still idiopathic or BVOD, BCH? Okay? If you see septal thickening, then I will be leaning more toward it's going to be more of BCH, BVOD. If you see with its lymph node enlargement, pleural effusion, pericardial effusion, then I'm going to suspect BVOD/BCH. I will keep saying BVOD/BCH. It's going to be difficult for me on CT to distinguish them apart, sometimes even in pathology. Okay? Group 2 is easy. You see, patient will be known to have left cardiac disease. You may see edema, pericardial effusion, pleural effusion. Group 3, you will see abnormal lung, either it's ILD, COPD. Group 4 is CTEPH. 2 things to look for: mosaic perfusion. I'm saying mosaic attenuation or perfusion. Will you see lung which is more opaque, which is normally perfused, and lung which is more lucent, which is hypoperfused. In practice, mosaic attenuation is it's going to be more common to be related to obstructive small airway disease. But if you see CTEPH, then it's likely because of small airway disease. Okay? Also, one clue, if you see subpleural scarring, it's indicating prior infarction and scarring. Group 5 is very variable. Okay? This slide is very important. If we see, this is the way we measure the trunk. Okay? Just before the bifurcation, measurement, it has to be perpendicular to the long axis of the artery at the level of the ascending aorta. Okay? I can tell you, I see frequently patients with 28 millimeter, 29, 27. If the patient is having low risk, for pulmonary hypertension, then the cutoff is suggested to be 34. This is like an incidental findings. If patient is known to have hypertension or suspected, then these are not really useful. Okay, it will not exclude hypertension if it's normal or within the normal range. Okay, so low risk, meaning clinically the risk of hypertension is less than 1%. The cutoff is 34, more than 34, and the ratio is 1.1. Intermediate risk, including CTD except scleroderma, history of PE, pulmonary hypertension, then it's going to be 32, more than 32. If it's high risk, patient with left heart disease, COPD, ILD, scleroderma, chronic kidney disease, sickle cell, then my threshold is 3 centimeter or 30 millimeter. Okay? If I will call these 30 in low risk, I will end up overcalling hypertension, and he will have plenty of referrals, okay, for normal exams. Again, this is the way to measure it before bifurcation, perimeter to long axis. And we compare this one to this one 38, 28, the ratio is almost 1.5. So this is concerning for pulmonary hypertension. As I mentioned, RV on CT is challenging. By looking, RV is way bigger than the LV, number one. The ratio of RV to LV is more than 1, and the septum is flat or straight. And the RV wall is thick. So combining both, we are dealing with pulmonary hypertension. Okay? This is the most useful slide. If you see it, it's the most common presentation. Enlarged PAs, the ratio is more than 1, normal lungs, idiopathic pulmonary hypertension. Okay? Just because we will be mentioning septal thickening and ground glass. Just a quick review. What is the septal thickening? The lung building block is the secondary lung lobule, okay? So this is the septum, and this is the secondary lobule. In the central component of it, we have the arteriole or artery, as well as the bronchiole and the bronchial tree. The veins will be in the septum, and lymphatic will be in both, peribronchovascular as well as along the septum. So when I say septal thickening, it's a thickening of the secondary lobule septum, okay? This is the secondary lobule. This is the ground glass, which is hazy opacification of the lung compared to consolidation, which is white or opaque. You cannot see the vasculature, okay? Just quick example, this patient with pulmonary hypertension, we see very mild, subtle septal thickening and patchy central ground glass changes. Patient was treated with vasodilators, so it's actually a case of PVOD, and patient developed edema, and otherwise it's important to distinguish POED from idiopathic pulmonary hypertension. And this is a very nice example of ground glass changes, okay? Anyone from the junior, what do you think? So significantly large PA, the ratio is more than 1. There's even calcification within the wall. What do you see here? Yes, ASD. So this is going to be group 1 under the congenital heart disease classification. This is another example of muscular VSD. This is an example of what we call sinus venous ASD. It can be easily overlooked, where we see the defect, the ASD defect, just next to the superior cavoatrial junction. And there is a very common association with partial anomalous pulmonary variation, especially from the right superior pulmonary veins. Okay? And this is an example of what? Anyone? Yes, this is a BDA, where we see a communication between the aorta and the pulmonary trunk. As I mentioned, left atrium is very helpful. It's enlarged, and there is calcification along the mitral valve annulus and leaflet. So we are dealing with left heart disease, most likely because of valvular disease. Coronary calcification, enlarged left atrium, septal thickening, ground glass effusion. This is a case of heart failure and pulmonary edema. This is interesting. So scleroderma is a common disease among the ILDs, CTD ILDs. It can cause hypertension in 2 ways, either vasculopathy or because of fibrotic ILD. So in this case, we clearly see fibrosis, right? Why I'm saying fibrosis? We see reticulation, ground glass opacities, distortion, and traction bronchiectasis and bronchiectasis. Compare this one to this one. Do you see fibrosis in this one? No, you see only just faint ground glass changes. In this setting, these are likely related to vasculopathy, and they are at risk of developing PVOD/PCH. Okay? Then the last one is the CTEPH. CTEPH findings is chronic occlusion, typically eccentric, linear, what we call band or whip-like. You can see multifocal areas of stenosis and narrowing. You can see complete occlusion, and sometimes you see that like very global peripheral hypoperfusion with very small vasculature, especially in patients with peripheral disease. Okay, now it's fun time. Can you scan it? So in summary, group 1, the most common one is going to be idiopathic, typically normal lung. If we see ground glass among group 1, it could be BVOD/PCH. If you see septal thickening, lymph node enlargement, pericardial effusion, this will support the concern for BVOD/PCH. But if we see ground glass, yet it's not BVOD, then one caveat. Idiopathic hypertension, they can have ground glass mainly because of two explanations, because of recurrent hemorrhage, and they can develop what they call cholesterol granulomas, or plexogenic lesions in patients with long-standing and severe hypertension. Okay, so ground glass in type 1 is not always BVOD/PCH. Okay, should we start now? Okay, case 1. If you see the cases, if you click on this one, it will open the case separately. So now we have case 1. I need someone to volunteer. I'll give you like 1 minute. You can give me the diagnosis or the pH group. No, someone should speak. Yeah. And the floor is open for everyone, junior, senior. Okay, now I need one to volunteer and tell me the findings or the diagnosis. Why it's not showing? I think you should. No, I think, yeah. This may be in the setting for the mouse is there. Yes, excellent. Okay, anyone? Any guess? Oh, okay. So I'm going to help you with the first one. Okay. Okay, so starting with do you think the trunk is enlarged? Yes. Even without measuring, it's definitely bigger than the ascending aorta, so the ratio is more than 1. Number 2, the RV is big, and the RV to LV ratio is more than 1. Septum is flat or straight, the RV wall is thick, right atrium dilated, and we see also reflux of contrast into the enlarged IVC and hepatic veins. So we are dealing with pulmonary hypertension, okay? Now let's just follow it out like lobar and segmental. So the trunk is okay, the right and left are okay. As we go down, we see something there. Maybe this one is faint, let's keep looking. Or another one which is more convincing, we see a whip-like filling defect, okay, which is extending inferiorly. And as we go down, look at this one. We see area of focal stenosis followed by dilatation, and we still see the filling defect, the eccentric whip-like filling defect. And if we go more distal to the subsegmental branch, it's becoming small and not visualized, okay? So now we are dealing with most likely SAPH, and we have to look more for more filling defects, okay? If you see in the left lower loop, the same thing starting here. Another whip-like filling defect. Okay. So now we diagnose SAPH. Can we guide management? Yes. If we follow the San Diego surgical classification, if the central artery is involved, it's going to be level 1. If it's more of the lobar and interlobar, it's going to be level 2. If we are dealing with segmental branch, it's going to be level 3. And if it's subsegmental, it's going to be level 4. As you go more proximal, there is a higher chance of success with surgical treatment. As you go more distal, maybe it's going to be angioplasty or just medical treatment. So diagnosing and guiding management is important role for CT in SAPH patient, okay? Now look, just assess the lungs. What do you think? So all of these in the periphery are actually post-ischemic scarring, also supporting diagnosis of SAPH. Okay? Do you think there is a mosaic attenuation? Although it's subtle, if I wouldn't do it for you, there is actually impressive mosaic attenuation. This opaque lung is more of normal perfused lung, but if you see the periphery and most of the loops are actually hypo or oligemic, okay? So when I see this extensive mosaic attenuation, despite you see maybe couples of filling defects, I know there is also a significant component of peripheral disease. X-ray near normal, but we see when you see fullness of the AV window, you should suspect enlargement of the pulmonary trunk. So nicely normal ventilation, homogeneous relatively speaking. Compare this appearance with this appearance. Okay, so classic example of SAPH, impressive SAPH. Okay, so case number 1 is done. Can you go now to skip case number 2 and go to case number 9? Or I can go over it quickly. This is just another example of SAPH with just maybe different imaging findings. As you go down to the left lower lobe, you see irregularity, near occlusive filling defect aside from small patent lumen, and the same thing happening here in the right upper lobe, eccentric filling defect, irregularity, the same thing in the right middle lobe. As well as the right interlobar artery, eccentric filling defects, irregularity, areas of narrowing and stenosis. So this is another example of SAPH. Okay, now just go to case 3. I will give you 1 minute. So this is a case of hypertension. Just my question, can you identify the cause of the hypertension in this case? What? Okay, anyone? Who? Excellent. So the PA is enlarged, the ratio is more than 1, the RV is enlarged, the wall is thick, and one of our checklists is to look for PDAs, right? So this is the aorta, and this is the aorta, and we see there's a communication clearly between them, which is quite sizable. Okay, patient even, this is like, I think 15 years or 10 years follow-up. You can see because of the severe hypertension, now the shunt is actually going from BDA to the aorta. Because we see contrast in the descending aorta, not in the ascending because of the shunt from the trunk to the thoracic aorta. So this is a case of BDA is going to be group 1 under congenital heart disease and shunting. Excellent. Next case. I'll give you 1 minute. Okay, so in this case, the same findings regarding the PA, the RV, no BDA in this case. But we also see multiple mildly enlarged lymph nodes in the mediastinum and hilar region, and we saw also pericardial effusion. So before even looking at the CT, we have something in our mind to think about. I mean the lung findings. Okay, so anyone? Excellent. So this is a case of BVOD. If we look carefully at the lower zones, we see areas of septal thickening as well as faint, small central background glass changes in both lungs and septal thickening. So this is a case of PVOD, went for transplant, I think 5 years ago. Okay, next case. I think this is case number. Yeah, this is case number 7. What? Okay, and what else? Yes, so we see the ASD, there's a defect in the interosseous septum. Any additional findings? Okay, excellent. So let's just look back at the normal. So this is the left inferior pulmonary vein going to the left atrium, right? And this is the left superior vein going to the left atrium. And this is the right inferior vein going to the left atrium. And this is even the middle vein, which typically will go to the right superior, but in this case it's separate and going to the left atrium. Now let's look for the right superior pulmonary vein, which is this one. It's actually draining to the SVC. Okay, so we are dealing with ASD and right partial anomalous pulmonary venous return. Okay, this is case number 8. Sorry? I think I like this. I think for me, this is going to be one of the differential in this case. Yeah, so the trunk is enlarged, the right artery is narrowed, and there is some soft tissue thickening as well as the left. So as we look carefully in this case, of course we have extensive chest wall collaterals, yes? Excellent. So this is a case of fibrosing mediastinitis. Patient had biopsy long time ago, suspecting TB. So this is a case of fibrosing mediastinitis. We see the tracheal thickening, soft tissue thickening, causing narrowing of the RPA with trunk enlargement. Again, RV is big with hypertrophy. And it's also affecting the airways as well as the pulmonary veins. So this is a case of fibrosing mediastinitis. Which group? 1, 2, 3, 4, 5. I think, 4 is maybe it's part of obstruction, but most people will label it as group 5. Okay. Okay, case number 11. So this is a known case of pulmonary hypertension. Can you tell me what is the most likely cause? Or which group? Excellent, group 3. So looking at it, especially in the mid and upper zones, we see along the bronchovascular bundle, we see ground glass changes, reticulations, significant distortion, as well as traction bronchiectasis. What else? What about the diffuse lung background? Excellent, there is impressive mosaic attenuation. And in this case, we have expiratory exams. Don't know why it's not opening. Yeah, I'm trying to show you the expiratory exams, but it's not opening. So with expiration, if the air trapping is because of obstructive small airway disease, because air is not escaping, so the opaque lung will become more opaque because there is less air now, and the lucent lung will remain lucent because of the air trapping. So this is a case of biopsy-proven ILD with obstructive small airway disease, so combination of both resulting in pulmonary hypertension. Okay, the good thing we still have time, so I will go back to one of the cases I skipped, case number 2. I think case number... case number 6. النت حقه مو مضبوط، حق اخصم عليها. So this one, actually, these 2 images are enough for case number 2. So patient known to have severe pulmonary hypertension came with chest pain. And this is one of the utilities of CT, apart from only assessing for causes of hypertension and CTEF. Excellent. So in this case, hopefully the axia will work. But this is the ascending aorta, this is the aortic root, and this is the left main coronary artery. And this is the massive pulmonary trunk. And this exam it has to be ECG gated to assess, okay? And as you see, there is acute angulation and there is severe stenosis of the left main coronary artery, okay? Luckily, these images are enough to see it. So this was actually stented. Do we have Dr. Noura Traifi with us? So this was actually stented. The patient did well. So I always have this question. Do you think stent will remain patent for a long time? I don't know. Okay.
It was actually a very good series on stent resistance. At least on the short term, it works.
Okay. But it's something, at least from diagnostic point of view, to keep looking for, especially if patients who come with chest pain and no explanation. It's something to think of. One last case. This one is special for Dr. Abdullah Dalan. Hopefully it's going to work. Because it's going to remind you of one case we discussed 2 months ago. Let me try my... Okay, good. So I want one of the fellows, one of you should speak. Shakir. Huh? You have to. مشكلتك إني شفتك. So what is the main finding here? So all of this is just flow mixing artifact. The RBA is way bigger, almost bigger than the ascending. So we are dealing with pulmonary hypertension, okay? RV is big and wall is thick. So what do you see here? So there is calcification and there is eccentric low attenuation. So it's likely chronic thrombi, okay? So do you think this is group 4? So this is actually a patient known to have long-standing idiopathic hypertension with in situ thrombosis. Do you remember that case? Well, that one was even more confusing. So they can have in situ thrombosis, which can calcify. So this is not CTIF. Okay. It's possible, but we don't see it commonly. So dissection typically is going to be a sequelae of intervention, like Swan's Gerter or.
Thank you so much, Dr. Ben Saidan. I think we have 15 minutes. We can open the floors for questions. Yes, please, Prof. Thank you.
Stop. Thank you very much. Great cases. Two comments. The first one is very severe cases. We don't even have those anymore. You have to look in Europe to find that. Maybe go eastwards. It's in Western Europe. It's very severe cases. And the second comment is for chronic thromboembolic pulmonary hypertension, mosaic perfusion is a diagnostic signal. What would be your guess? How many % of the patients do have that?
So most of them will have mosaic perfusion. Some of them you have to window it carefully to find the mosaic perfusion. But most of them, in my experience, I will find the mosaic attenuation. But for me, I have a lower sensitivity. I usually look for it carefully. And sometimes it's a supportive finding. If I see bronchial collaterals, history of PE in the previous CT, and mosaic attenuation, and areas of infarct with scarring, I will be leaning more toward CTIF cases. So for me, it's very common with CTIF and common in other categories or classes. This is number one. Number two, we are lucky to have our backs available even like 25 years ago. So the BDA case is actually from 2005. The BVOD is from 2015. So
congratulations, really instructive cases.
Thank you.
Any questions from the audience? I think Dr. Nawal has a question.
Thank you, doctor, for these interesting questions. So how do you tell the difference? How do our chest radiologists are supposed to tell the difference between acute pulmonary embolism and chronic thromboembolic pulmonary hypertension? I mean, the web defects can be mistaken for just filling defects. And the other thing for the mosaic perfusion, the patients with a small airway disease can present with such hypodense areas.
Yeah.
Do we still do the expiratory films that can differentiate between the small airway disease and the same mosaic appearance due to pulmonary hypertension? Thank you.
So thank you very much. So the first question, in radiology we say previous is your best friend. If I have previous exam with PE, acute PE, it will be very helpful. But even we know CTIF patient, most of them, even if they present acutely, they already have chronic PEs. Okay? So the findings typically for the acute, it's going to be usually central, not very eccentric or linear. You don't have that much, you may have expansion of the artery, but no stenosis and irregularity. So the eccentric filling defects, web-like or linear or band-like, areas of irregularity within the wall and retraction, areas of multiple channels within it, sometimes even like, especially in the periphery, areas of very small attenuation. And if you window it carefully, you see this, you don't see that much contrast in the lung periphery. Areas of focal stenosis and areas of narrowing, all of these support the CTIF or the chronic PE. Like we know that there is a CTIF and there is CTID. So usually it's, sometimes when it becomes subacute, maybe difficult. But for me, if something to cause pulmonary hypertension, you will find clear-cut imaging finding to support your diagnosis. But again, previous is your best friend. And the mosaic, hopefully this one is going to work now. Can I go back? Yeah. So this is the case of ILD and obstructive small airway disease. So for the trainee, when you see the trachea is rounded, then this is good expiratory. In this case, it's like a dynamic, so it's free breathing in the same level. So now, you see there is bulging of the posterior wall, so this is expiratory. Notice the area which was loosened remained loosened, okay? While the areas which were actually more opaque, now it's becoming more opaque because there is less air now, okay? So this is very helpful, but if I'm dealing with CTIF, and I know I'm confident it's a CTIF, they can have asthma. Asthma patients, they can have mosaic attenuation and air trapping. So if I see strong evidence of CTIF, I don't typically ask for respiratory exam. I just think it's most likely because of CTIF. And usually it's going to be more segmental, even subsegmental, more larger and more toward the periphery. If you remember the first case, the more opaque lung is more central, but it's going to be more peripheral in case of CTIF.
Professor Dalan also has a question.
Thank you, Menahi. Remember, we among all this 500 patients we had 2 cases where we had completely normal VQ scan, but the CT angiogram was actually abnormal for CTIF. You and I, we discussed this many times, and I just wanted to throw this also for the audience. I don't know if you have explanation to explain for the audience, or have you ever seen anything after those 2 cases when we discussed them together, remember?
I think that case is for me still puzzling. I discussed it with my nuclear medicine colleagues, with other colleagues in my thoracic section as well. That was really puzzling because of 2 reasons. I just showed it to my colleagues in thoracic section without telling them any history. And they looked at the CT and said, oh, this is CTIF. I showed it to my colleagues in nuclear medicine without giving them history or looking at the CT. I said, what do you think? They said, this is not CTIF. So, and what make it even more confusing, because it has some areas of eccentric, like this one, filling defects with calcification, but it has areas of more of linear web-like filling defect, mosaic attenuation, bronchial collaterals, and even suspected areas of scarring. So in that case, I'm still puzzled. I don't know. I think it's still maybe a combination of both. Started as long-standing severe hypertension, maybe with in-situ thrombosis and some showering thrombi. But the VQs was the one which was confusing to us.
Thank you for this interesting discussion. We found in a paper published, I think, 15 years ago, that the more severe the hemodynamics, the more even is the perfusion on the VQ. This is a paper published by SKORO. And I do think that distal CT-EPH is a real problem. The CTIF of splenectomy sometimes is very homogeneous.
Yeah.
So VQ isn't everything. I think the gold standard is angiogram, the invasive angiogram. And I do believe Professor Matsubara will show you.
So you will believe more in CT than VQ scan?
I believe, well, altogether.
CT angio.
I believe more the invasive angio than the CT angio.
So do you think you will go for conventional angio in that patient? Okay.
I think that's the truth.
Yeah.
Thank you so much. I have a question, if you allow me, regarding the same areas when we're talking about the VQ scan and the CTBE versus the angiography. So my question is, there is some cases with severe pulmonary arterial hypertension and also PVOD where they have mismatch in VQ scan. So in these cases, do you think we should proceed with more further investigation with angiography and CTBE?
So the mismatch was between what, CTIF and PVOD or what?
Mismatch in VQ scan.
Okay. And
so
the patient with PVOD?
PVOD, yes.
Yeah, so they can have it, but honestly, I need to look at it. I showed you a very classic example of very positive CTIF. If it's something very positive, I don't think PVOD will present with similar example I gave you. They may be heterogeneous, maybe areas of more of mismatch, yes, but it's not going to be as impressive as this one. But I mean, in medicine, there's no black and white. If you encounter such case we encountered 2 months ago, then maybe going for conventional CAF is the answer.
Thank you so much. So do you think that if we screen a patient with VQ scan and it was positive, we should also do a CTBE? And if the CTBE didn't show any evidence, as usual, sometimes it's required a very expert CTIF radiologist to see the defect. Do we consider the angiography?
So the issue with VQ scan is if you have previous VQ scan and now it's persistent, we know it's a chronic, then you can say it's CTIF. If you have only one VQ scan, then we don't know is it acute or chronic. Number one, so that why you need CT to assess for chronic PEs. Number two is guiding management. You need CT to see are we dealing with proximal disease or mainly peripheral disease.
And if it's negative, the CTEPE?
If it's negative, then yeah, maybe going for conventional. But CTIF, I expect to see something.
Okay, thank you so much.
Welcome.
So do you have any questions from the audience? Still, we have 5 minutes. I think we are done now. Thank you so much, Dr. Ben Saedan. It was very brilliant talk from you. Thank you so much.
Thank you.
5 minutes break, then we will come back to the second session.
Assalamu alaikum. Good afternoon, everyone. I'd like to introduce Dr. Steven Rosenkrantz. He's going to be presiding over our second workshop. Dr. Rosenkrantz is an interventional cardiologist and the head of pulmonary hypertension at the University of Cologne in Germany. He's one of the most widely published pulmonary hypertension experts in the world. And he's going to give us the workshop, basically state-of-the-art right heart cath, for all or part of an hour. It doesn't have to be an entire hour, but we just want it to be as informative as possible. Dr. Steven, go ahead.
Thank you very much, and I would like to start and thank you also for the invitation again. It's always a pleasure to come to SAPH. I've had the pleasure to come here for several years now. I see things developing, and obviously it's a great success, and particularly I really like this kind of session where we have a workshop for the younger colleagues, but also for the more experienced, and the last talk just showed how important it is to stick our heads together and look at details in this context. So it's a pleasure to be here again. So let's talk about right heart catheterization now. And it may seem pretty easy. We just put a tube in, we get some values, we take the tube back out, and then we know. And those of you who do this know that in the end it's not that easy. And if we have a specific patient in front of us and we do a right heart catheterization, there's an indication for this invasive diagnostic procedure, and there's a clinical phenotype, and then we also have other information about the patient that we have consider whenever we do a right heart cath. And that's something, I say this because in routine care, a patient comes to the cath lab, someone might do it who doesn't even know what's wrong with this patient or why it's done. Tube in, pressures, tube out, that's all we get. And that's not sufficient. So what we want to know in the individual case is the relationship between filling pressures on the left side, whatever happens in the pulmonary circulation, and there's a lot to measure, and then also the response of the right heart to an increased afterload. And if we consider the right heart, it's even more complicated. Usually in the field of pulmonary hypertension, we say we have a pressure-loaded right heart. But what happens with the right heart? It dilates, usually, if we have an increased afterload. And then we have functional tricuspid regurgitation on top of that. So we can also expect a volume load in addition to the pressure load. So a lot to detect. And if we now go beyond the cardiopulmonary interaction, hemodynamics are then also really important for other organ systems. And if we consider this, that slide contains two things, on the left and on the right. If we have right-sided heart failure, that causes congestion into the venous system and into multiple organ systems. At the same time, in patients with group 2 PH, a left heart problem, we can expect a low systemic output to start with. In patients who have group 1 or other forms of pulmonary hypertension due to the dilated right heart, the septal shift to the left, we have a chronic underfilling on the left side, and therefore also in this condition a low output. So we have a combination of congestion on one hand, low output on the other hand, both hemodynamic measures if you want, that then trigger an inflammatory syndrome that then has a second hit on multiple organ systems, and the predominant example here is a cardiorenal symptom, worsening renal function, and we have learned that the left side here, the congestive part, is much more important for worsening renal function as opposed to the reduced filling pressure. So that's important to consider as a systemic condition. Then, obviously, we have the definitions for pulmonary hypertension for pre versus post-capillary pulmonary hypertension. So it's the mean pulmonary artery pressure. We have adjusted the cutoff there. It's the wedge pressure. It's the pulmonary vascular resistance. We have also adjusted the cutoff to define precapillary pH or a precapillary component. And then usually we measure hemodynamics at rest. And we have to make clear whatever we measure is at rest, usually in the spine position. It's a snapshot at a specific point in time, and patients get symptomatic with exercise. Things happen hemodynamically with exercise. So exercise pulmonary hypertension is also something to consider, and the updated guidelines have provided a new definition for exercise pH, which is based not on pressure, but on the slope of the change of mean pulmonary arterial pressure and cardiac output with exercise. So if we consider the ESC-ERS guidelines, we have specific recommendations for right heart catheterization in terms of confirmation of a diagnosis of pulmonary hypertension. We know that echo alone gives us important information, but it's not sufficient for a precise diagnosis and hemodynamic assessment of pulmonary hypertension. And then if we consider the definitions and the cutoffs, it's the mean PA pressure, it's the wedge, and it's PVR. Here is a table of the values that we should measure or calculate. So it's far beyond those three measures that are in the table. We need to get all of this to really understand hemodynamically the condition of the individual patient. So let's get to practice here. Now we're in the cath lab or wherever you do it, and we do a right heart catheterization. We have a Swan Guns catheter, we have all our tools, and now we get started. And when we talk about right heart cath, I also want to put the finger in the wound here and there, where we make frequent mistakes, all of us. So let's start with this, the trivial things. Sometimes we get values that maybe do not match with what we would have expected from echo. So where do we put our pressure transducer related to the patient's body? And if we consider textbooks, scientific documents, scientific publications, it's all over the place, if we're honest. So there are different rules here that are listed from A to D. That's where we could put our pressure sensor, and we will find literature and references that support each of those. So here's a question for you. What is the zero level of your transducer? In other hands, at what height do you position it during spine right heart catheterization? Is it A? Is it B, C, D, or is it E? We don't know. Let's do some hand raising here. Who says A? Who says B? Who says C? Who says D? Who says E? Oh, a couple hands for E. So good that we talk about it. So here is a nice work that was published many years ago by Gabor Kovac and the group from Graz in Austria. And they have done a lot of work for us to understand what impact it has hemodynamically where we put the pressure transducer. So what we see in the table below is the difference in millimeters of mercury depending on where we put the pressure transducer. And now if we consider, for instance, a cutoff for the wedge pressure of 15 millimeters of mercury, that has great impact on whether we would define a patient as pre- or post-capillary pulmonary hypertension, for example. So it's important. Furthermore, they have looked precisely and related their findings to imaging. We just talked about imaging a lot, and what we want to know is where is the correct level of the left atrium for the majority of the patients. And based on this work, the recommendations in the European guidelines, but also in other documents now, is to put the 0 point at the mid-thoracic level. That's where it should be. And we have to do this. Sometimes, particularly in cardiology cath labs, they might be so busy and there's the next MI coming and now we have to do a right heart cath, so patient in, we have to be quick. We have to take the time to really do this Otherwise, we will measure something that is not really valid, and then if we once have done a right heart catheterization and we have not measured properly, what's going to happen? This test result of the invasive testing will then be there in numbers, and we make our decisions based on these numbers. So it's important to take the time and do things correctly, even these seemingly trivial things. All right, so now we have put the catheter in and we record the wedge pressure with the inflated balloon, then we deflate the balloon, we get seemingly very nice pressure tracings and waveforms here, then we pull it back into the RV and then further back into the RA. So what we need to do is we need to record the wedge pressure, we need to record the systolic, diastolic, and mean PA pressure. We need also to record the right ventricular pressure, systolic, diastolic, and diastolic, as we do for the left. And we have to record the mean RA pressure. And there are cases where we sometimes may have pulmonary valve stenosis, or in rare cases, pulmonary angiosarcoma, which could be at the level of the valve. There could be other things present. Recently, we had a congenital heart disease that was very complicated, that gave us a pressure gradient within the RV. So it's important to really document all these pressures that are listed here. And then at the bottom in the gray box, we also have a couple of additional measures and calculated variables. So what are the calculated variables? We have number one, the transpulmonary pressure gradient, TPG, as the difference between the mean PA pressure and the wedge pressure. And then we calculate pulmonary vascular resistance if we relate the transpulmonary gradient to cardiac output. In this context, I also want to remind ourselves of the fact that this calculated PVR has various components. And we tend to say, okay, if the PVR comes down, good, that's positive. The PVR can come down because we drive cardiac output up and your wedge pressure rises. Both of these things are not necessarily good in the long term. So we have to also consider the individual components of pulmonary vascular resistance and not only blindly rely on PVR. The second gradient then is the diastolic pressure gradient, or DPG, difference between the diastolic PA pressure and the wedge pressure. And then something that we look at more and more is the pulmonary pulse pressure, which is the difference between the systolic and the diastolic pulmonary artery pressure. And if we relate stroke volume to this pulse pressure, we can calculate the pulmonary arterial compliance, which, after all, may be the best prognostic indicator for different forms of pulmonary hypertension, including group 1, group 2, group 3. So there's a lot of information here that we may capture. And then just one word about cardiac output measurement. The gold standard is considered the direct fix method that very few labs do. It's complicated to do. And if you don't do that, then the preferred methodology clearly is thermodilution. The indirect FIC is not really recommended. It's acceptable according to the guidelines, but clearly thermodilution is the preferred methodology for measurement of cardiac output. And here, for the younger colleagues, the rule is you have to repeat this measurement. You inject ice-cold saline, and you have to repeat this measurement at least 3 times. And each of the measures, each of the values should not differ more than 10% from the mean value that you get. So if you measure cardiac output, why is that so important? We need it to calculate PVR. But also, if we have right heart failure, as a consequence of pulmonary hypertension, the cardiac output will be low. In this context, it's really important how the right heart and the right ventricle adapt to the increased afterload. And there is a terms of adaptive or maladaptive hypertrophy, or there are also the terms of homeometric versus heterometric RV adaptation. So from a normal right ventricle, there may be homeometric adaptation where we have a hypertrophic response in the right heart with preserved function, also preserved contractile reserve with exercise. And then in the later stages or in different patients, it turns into heterometric adaptation, which is considered uncoupling of the right heart to the increased afterload. So the adaptation of the RV related to the measurement of cardiac output is also clinically relevant. In this context, there has been a very nice study, primarily published by Jotretello, who's in the audience here from the Gießen group. They have looked at exactly that, homeometric versus heterometric adaptation. It's a very complicated study, exercise hemodynamics with conductance catheterization. The bottom line here, is that's why I show it, is the prognostic impact of the adaptation of the RV in patients with PAH. You see the survival curves here, clinical worsening on the left, and then survival probability on the right. That's the huge difference that you see depending on the adaptation of the RV. So it's really important. Back to the simple hemodynamics. And here I want to simplify things for a moment for us to be reminded of the interrelations in the pulmonary circulation. And here we look at only two measures. On the left, as you see, it's the mean PA pressure. On the right, it's left atrial pressure, or if there is no valvular heart disease, should be similar to the wedge or to the LVEDP. And then we have the red line. That's the 20 millimeter cutoff that defines pulmonary hypertension. And then we see the black dots. We have a patient where we measure everything. We have a mean PA pressure of 15. We have a left-sided filling pressure of 8. The difference between the two would be the transpulmonary gradient. It's 7. So everything good here. And now we have this. Now we have a normal left-sided filling pressure, but we have an increase in the mean PA pressure that's quite prominent. Now the TPG 40 minus 8 is 32 millimeters of mercury. And if we relate that then to cardiac output, most likely we'll get a PVR of more than 2 Wood units. So this is a typical picture of precapillary pulmonary hypertension. And now we may have this. Now we have an elevated left-sided filling pressure. And what does this mean if we think about that for the pulmonary circulation or for the lung as a whole and for the right heart? If we have an increase in filling pressure and the lung and the right heart wouldn't react to that, the blood would flow into the wrong direction and the patient ends up in pulmonary edema or dies. So the lungs have to react to that, and they do that by something that we may call protective or reactive pulmonary vasoconstriction. And the lungs do that in order to maintain a positive pressure gradient across the lung. Now, by definition, we have pulmonary hypertension. The TPG is positive. It's now 30 minus 18 here would be 12. So we have, by definition, post-capillary pulmonary hypertension. And the PVR in this context may be normal, so that could be a hemodynamic profile of a patient with isolated post-capillary pulmonary hypertension. If in this condition we give a pulmonary vasodilator, may it not work, but we may do harm. Why? Because we may drive the patient to go from here back to here. So it's important to consider the hemodynamic state for treatment decisions and not just give a patient with pulmonary hypertension sildenafil or something, or tadalafil, that can be hazardous for the reasons that we highlight here. So unfortunately, things can be even more complicated. We may have an elevated filling pressure on the left, and now we have a pulmonary artery pressure rise that exceeds by far what we would have expected from the increase of the filling pressure on the left side. So now again, we have a high TPG, and if you consider the calculation related to cardiac output, most likely we will now have an increase in PVR. So that is then the clinical picture of combined post and precapillary pulmonary hypertension, a patient who may have HFpEF, for instance, and CTEPH, HFpEF and pulmonary vascular disease that may develop over time if constant congestion into the pulmonary circulation is a chronic issue. However, when we see something like that during a right heart catheterization, we also have to consider the volume state of the patient. We should perform right heart catheterization in the fully recompensated patient, not volume overloaded patient. And if we see something like this in a volume overloaded patient, that doesn't really tell us something. So we have to repeat the right heart cath after full recompensation. And when we do this, the lesson here to be learned is that this additional increase in pressure and also resistance can be highly variable. If we optimize things on the left side, the pressure may come down quite dramatically in individual patients. However, in others, we may bring the wedge pressure down and the PA pressure remains high, and that then is a different hemodynamic profile in the individual patient. So, we have, if we consider the guidelines, we have echo, specific recommendations, imaging of the right heart. Then we have this list of variables during right heart cath. And I now want to focus on how to use echo, and particularly how to measure and interpret the wedge pressure. Because this is something that we're all struggling with, including myself, including experienced doctors that know a lot about this. It's just not trivial to measure a correct wedge pressure. And at the latest World Symposium, there was a lot of debate about whether 15 is the correct cutoff, should it be lowered to 12? There was a lot of discussions. In the end, the decision was no, 15 is probably correct. There had been two key studies that were shown there. One is on the left, and I put a red circle around it. That's the upper limit of normal for the left pressure, for the wedge pressure, if you consider normal subjects. Might be 13, but on the right, it's the response to targeted PAH therapies across the range of wedge pressure. And that studies, bless you, have shown that it's at least effective up to 15. And if the drugs work up to 15, then it's probably not right to change the cutoff. Back to the measurements of the wedge pressure and potential issues there. As I said, and as you know, it's not trivial to measure this correctly, and we have here a couple sources of error. At the top that's what we want. We want the balloon to obstruct the blood flow completely, and we want the tip of the balloon free in the lumen so that we get a correct pressure tracing. Example 2 shows you an incomplete obstruction, so we have a damped PA curve and not a wedge. And C and D are sources for so-called over-wedging, and the pressures here can be too high, too low. Both is possible. We usually see a flat line and not the typical waveform characteristics of the wedge pressure tracing. So the balloon can be squeezed at the top, or the tip leans against the wall, so we don't have a proper recognition of the pressure. And now it's even more complicated. Now we have this. We have respiratory swings. The blue line here is the wedge pressure. We have respiratory swings, and the question is, where do we take the reading here? That has great impact. If we now consider exactly that pressure tracing, and the white line is the cutoff that discriminates between pre- and post-capillary, and now we take either the mean value across the respiratory cycle, or we take the end expiratory, so it's red or green. In the individual patient, in the same patient, same pressure tracing, we would come up with two different diagnoses that has direct implications on our treatment decisions. In center A, that uses the red, it would be precapillary, presumably PAH. In center B, it would be postcapillary, and we would not treat PAH. So this is important. So here's another question for you. Where do you take the pressure readings in relation to the respiratory variations? At end inspiration, at end expiration? Do you take the mean value across the respiratory cycle? It depends on the specific situation. Or again, E, I don't know. Let's do a hand raise again. Who says A? Good. Who says B? That's about half. Who says C? That's 3. Who says D? Sorry, I didn't hear the question. Yes. Okay, good question. What about holding the breath? So the recommendations are do not have the patient hold his or her breath because the patients may go up and then you measure not the right values. Accept the respiratory variations, and they can actually be a quality criterion that tells you that you are in the correct position. When in doubt, and you have the balloon inflated, you could also draw a little blood sample, and the expected oxygen saturation in the wedge position would be high. But the clear recommendation is do not do a breath-holding maneuver. So you may also argue D. I saw Irene Lang raise her hand for the mean across the respiratory cycle, very experienced professor from Vienna. The guidelines say something different, as you probably know. The guidelines say do the reading at end expiration, the end of normal expiration. But then it may come down to the individual patient. If we have patients with pulmonary diseases, including COPD, the respiratory variations may be very pronounced. So then in the end, we have to consider the individual case, but the recommendations in the guidelines for the majority of the patients is to take that reading at the end of normal expiration. The next thing is the volume load. Obviously, the filling pressures, particularly if you have a patient with a stiff left ventricle, depend on the loading conditions of the individual patient. So we may say that we have a gray zone between 13 and 15 millimeters of mercury. We may say that if it's below 12, it's very likely that it's true precapillary pulmonary hypertension. If it's above 15, by definition, it's postcapillary. And then if we are in the range between 13 and 15, we may consider a so-called volume challenge to unmask occult HFpEF. The cutoff here is then not 15 but 18 after you give the patient volume. However, we can also turn this entire thinking around, and we can say if we start a patient that has a high wedge and we diurese this patient, so it's a volume depletion, and your PA pressure remains high, but the filling pressure goes down, the wedge goes down, then we kind of unmask occult pulmonary vascular disease in these patients. So I guess it's important in both directions to give the patient volume, to get rid of volume. We can learn something in this context. We have published criteria for the measurement and reading of pressure tracings, particularly the wedge. We have listed here factors preventing correct interpretation of pressure tracings, and also we have criteria for valid wedge measurement that are listed at the bottom here. I don't want to go through that in detail, but this is something that we should really consider, and I spend a little bit of time here on the wedge because I think it's really important and it's really tricky to measure correctly, and we should teach that it's tricky. We should teach that we're making mistakes, and we should not rely only on this one variable when we give the patient a label of a disease in the end. And I want to even focus more on that with a couple of data that we have from the COMPARE registry that's shown on the left. And that's quite interesting. In this registry, we have patients in red. They are group 1 and had a wedge below 15. All good. Then we have patients in blue who are group 2 and have a wedge above 15. And then we have the group in the middle that's quite large, where the hemodynamic profile did not match, at least not by the criteria that we have, the diagnosis that was put into the system. And that's probably not by mistake, but it's due to the fact that the investigators were sure these patients have left-sided heart disease, but the wedge is, let's say, 14.5. Then it was group 2 PH. So on the right, we see the cutoff of 15 discriminating between pre- and post-capillary pulmonary hypertension. There has been published work that there is a zone of uncertainty between not 12 and 15, but 12 and 18, that was the definition. And further data, including Compara, but also other databases, suggest that this zone of uncertainty is even higher. Now, what percentage of the patients that we see in routine care falls into the zone of uncertainty? That's the majority of the patients. So that highlights that the wedge can lead us into the wrong direction, and we have to know that. So in this context, Marius Hüpper has published a little statement in Circulation recently where he put on the left side how we do it, how it is defined, to discriminate, in this case, between IPAH and PH-HFpEF, probably the most tricky differential diagnosis, and then a potential new concept where we do not rely on the wedge only, but have a diagnostic score that is based on clinical variables, echo in particular, and then hemodynamics, but not only considering the wedge, but also other variables, including the mean PAP and the PVR. And then we may come up with a diagnosis of definite or likely IPAH or HFpEF CP-CPH, highlighting that particularly the wedge pressure doesn't always give us the true answer, and we have to highlight that. So in this context, the echo profile comes into play, which is really important. We can have patients with heart failure and pulmonary hypertension that on echo look completely different. So we have to consider the echo picture, the echo phenotype, in addition, we have to interpret this together in addition with invasive hemodynamics. And in this context, in the recent Cologne Consensus Conference, we came up with this related to group 2 PH, that we integrate hemodynamics, the echo phenotype, is it a left ventricular or a right ventricular phenotype, and also the RV to PA coupling. 3 components here that we should interpret together. And then in this context, we may have patients without PH. We may have patients with elevated pressure but normal resistance. That would be the PVR between 2, so IPCPH. Or we could have patients with moderately or severely increased pulmonary vascular resistance. And then the colored boxes at the bottom discriminate for each of these conditions between a left or a right ventricular phenotype on echo. So whenever we have on echo RV larger LV, something is wrong in the right heart and the pulmonary circulation, and that might also help us to better classify our patients. So it's integration of invasive hemodynamics and also imaging findings. And when we talk about that and we perform a right heart catheterization, it's important to have the patient's clinical scenario in our heads and the echo findings. I see this not seldomly, that I'm called into the cath lab, there's a young patient, wedge is 22. And I said, that can't be the true wedge. And it may look, considerably right. But then we have to ask ourselves, why would the wedge be 22 in such a patient? So it's important, if we have suspicion of PH, to do the basic evaluation. And based on this basic evaluation, we should have a suspected diagnosis. That can be precapillary PAH or postcapillary or whatever. We should have that in our head. And then when we do the measurements during right heart cath, we have to ask ourselves, whatever we measure, does this match our suspected diagnosis, yes or no? And when we then fiddle around more with our balloon, all of a sudden, choop, then the wedge is not 22, all of a sudden it's 8. It may look right, but it has to make sense related to the clinical scenario and particularly echo findings. And this is, I'm really saying this because this, in my view, is a very frequent mistake that we make that has direct implications for our treatment decisions. If we say the wedge is 22 and we accept that in a young lady, we miss a diagnosis of PAH and we would not treat it, and vice versa. We may falsely treat patients if the wedge is measured falsely too low. So it is really important. And then we called this the 3 C's here when we do the right heart cath. Confirm pulmonary hypertension. Obviously, the mean PAP has now been adopted to 20. We have to get the complete hemodynamic profile, not just pressure and then tube out. And we have to characterize by the wedge or the LVEDP as pre or post capillary. But when we do that, we have to be aware of the limitations and uncertainties of the pressures. And then if we ask ourselves, is this measurement consistent with the suspected diagnosis? If the answer is yes, we have a, let's say, working diagnosis. If the answer is no, we may consider additional testing, be it a volume challenge or exercise testing. And then if we move down in this algorithm, the working diagnosis may be PAH, we treat accordingly. It may be PH left heart disease related to HFpEF, HFrEF, or other things. And then we consider still the DPG. It's not a definition, but it's important to measure. And then the PVR to discriminate between IPCPH and CPCPH if we have post-capillary pulmonary hypertension. And then there are specific situations. I want to focus very briefly. When we do a right heart cath, we must not forget if it is a new diagnosis of IPCPH, APCPH, or DPAH, then we should perform a vasoreactivity testing. In the updated clinical classification of the World Symposium, this is amongst idiopathic pulmonary hypertension, there's a subgroup called long-term responders to calcium channel blockers. And there has been a little bit of debate in the field. Should this be the correct diagnosis for these patients who have a specific entity and a specific response to vasodilators, or because you don't know whether they are long-term responders when you do the testing, so what are you going to write in your letter? Or, like in the guidelines, it's non-responders or acute responders at vasoreactivity testing. I'll leave that up to you what you like better, but in terms of the right heart cath and you perform the testing, I would argue we should document, is it a responder or non-responder during testing? So that's question 1. And then we have a specific algorithm in the guidelines for that acute vasoreactivity testing. We have the responder criteria, drop in mean PAP by at least 10 to below 40 without a decrease in cardiac output. And then we have the recommendation as a therapeutic consequence, high-dose calcium channel blockers for the responders. But the next recommendation is that we need to closely follow these patients. Sometimes we see this, vasoreactivity testing done, calcium channel blocker, okay, everything's fine. Everything's not fine for many of these patients. We have recently published this article on acute vasoresponders in the, if you wish, modern management era of PAH. So what we have looked at is the treatment pattern over time in all vasoresponders. The yellow patients died. In the red patients, the calcium channel blocker had to be withdrawn due to side effects or other reasons. And then we have monotherapy in the lighter blue and combination therapy, calcium channel blocker with another PAH-targeted drug in the darker blue. And then considering the definition of a long-term response to calcium channel blockers in the guidelines, you see the survival rates on the right. So overall survival is quite good, but a huge survival difference between the long-term responders to calcium channel blockers and the non-responders. So it's important to follow these patients. And I show this here related to right heart cath because maybe we can get additional information to the responder criteria that we have now. So in this cohort of patients, we looked at several things. One was the change in pulmonary artery pressure during testing, and the patients who went to above a value of 2.5 for PAC had a better long-term survival as opposed to the patients who did not. And as shown on the right, the change in PA compliance during acute vasoreactivity testing was also a predictor of the long-term response to calcium channel blockers. So more information to capture. If you do the right heart cath, you do the testing, you may consider PA compliance in addition to just the change in pressure. Then briefly, exercise right heart catheterization. The green box on the left refers to a diagnosis of HFpEF. So that's heart failure recommendations, heart failure guidelines. If you have a normal filling pressure on the left side at rest, and then you exercise the patient and your wedge increases to equal or above 25 millimeters of mercury, by definition, then this is HFpEF. On the right, that's a different question to ask during right heart catheterization. This is about pulmonary vascular disease. And here it's the slope of mean PA over cardiac output between rest and exercise as highlighted in the pulmonary hypertension guidelines. So when you do exercise testing during a right heart cath, there are different questions you may ask and there are different parameters to answer these questions. And the importance of exercise pulmonary hypertension was highlighted in this paper that was recently published by Gabor Kovac and colleagues, highlighting the prognostic relevance of exercise pulmonary hypertension. So what was done in the guidelines, this new definition seems to be important for patients, and that is irrespective of the underlying cause of pulmonary hypertension. Then we may perform right heart catheterization in different contexts. We may have patients with suspected pulmonary hypertension. We also may have patients with acutely decompensated heart failure or cardiogenic shock or pre-transplant, LVAD patients. I'm not really focusing on this here, but I just wanted to briefly show you this paper because in the context of heart failure, this is something interesting to read. And there was an additional one published by Katharina Zeder recently in the European Heart Journal, also focusing on heart failure. And if we now briefly talk about hemodynamics in the context of group 2 PH, now we called it the good, the bad, and the ugly here. And this refers to patients, the good are the ones who have left heart disease, where our treatment of left heart disease completely normalizes the filling pressures, and therefore we wouldn't expect pulmonary hypertension anymore. The bad are the ones where we do not achieve complete normalization of filling pressures, and in this context, the pressure is elevated, the resistance is normal, IPCPH. And the ugly are the ones that also have pulmonary vascular resistance because they have the poorest outcome and the highest disease burden. And in this context, I want to briefly now only focus in the last few minutes on remote PAP monitoring and heart failure. So that refers to little pressure sensors that we can implant into the pulmonary circulation in patients with heart failure. It's approved in Europe and the US for heart failure. And in heart failure patients, they decompensate, then we recompensate them, and we have this red curve here, a downward shift, more frequent hospitalizations and decompensations over time associated with a high mortality. And then we have different strategies to modify this to the better. One is disease management and clinical monitoring programs. And the best data have been achieved with invasive hemodynamic monitoring using such cardiomems or other devices where the patient can take pressure readings as we would do in a right heart cath in the hospital invasively on a daily basis. And the concept behind this is what we see on the top here is what we usually do or what usually happens. The patient decompensates over time. There is a preclinical phase of decompensation that we are not able to capture. Then the patient is hospitalized, we recompensate, so we are reactive. And if we consider pulmonary artery pressure, there is a certain time frame in the pre-symptomatic phase where we get hemodynamic decompensation already without clinical decompensation. And that's a time frame where we can adjust heart failure medications in a timely manner and prevent a clinical decompensation. So we have different devices that we may use in this context that measure either pulmonary artery pressure or left atrial pressure, as on the right. This is a CardioMEMS that we can implant, and I know that in this region it's utilized more frequently, so that's why I want to show it here. The patient has this little pillow, and he or she can press the button and transmit pressure tracings and values to the center. And then the center has to do something with that information. And this was the pivotal CHAMPION trial published 10 years ago now, showing a dramatic reduction in rehospitalization rates in both HFpEF and HFrEF patients, so preserved or reduced left ventricular ejection fraction. That was not achieved by pH drugs, but by optimized utilization of heart failure medications. And what is shown here is the medication changes in the treatment group where the doctors were aware of the pressures, or the control group where they were not aware of the pressures. So, knowledge about pulmonary artery pressure remotely monitored invasively by the patient triggered many more medication changes in heart failure patients, and that then was able to prevent hospitalizations. In particular, if we look at the different drug classes here, the most prominent changes were diuretics, which tells us that we underuse diuretics in routine care in heart failure patients. There was also the MEMS-HF trial in Europe, looking at the same concept. Here you see that when you do this, you're able to reduce pulmonary artery pressures in heart failure patients over time. You also see that this concept works irrespective of the hemodynamic profile, IPCPH or CPCPH, and on the right, everything that goes towards the left is in favor of this concept for reduction of hospitalizations. So this also works irrespective of the hemodynamic phenotype. The latest example showing very similar results published recently in The Lancet was the MONITOR-HF trial, confirming this concept. When we talk about drug treatment, now group 2 pH, it's diuretics that we have learned. It's also SGLT2 inhibitors that reduce pulmonary artery pressure, shown in patients that were equipped with such a CardioMEMS sensor. And last 2 to 3 slides focus now on mortality in this context. So on the left, we see data from the French Heart Failure Network showing the mortality rates in green, no pH, heart failure patients, in yellow, IPCPH, in blue, CPCPH, based on the refined criteria to define that, and it's clearly prognostically significant. On the right, we see a recently published pooled analysis of the 4 major studies that investigated CardioMEMS, more than 4,000 patients. And it's about the prognostic relevance of the pulmonary artery pressure at the time of sensor implant, diastolic, systolic mean. You see the curves. It's clearly prognostically relevant. And these investigators also looked at the prognostic relevance of changes in pulmonary artery pressure in the context of heart failure. If you focus on the table on the right, it's the diastolic, systolic, or mean PA pressure, and then you see pressure changes minus or 2 millimeters of mercury. It's not a lot. And then you see the impact on survival rates, minus 14.7, plus 26.7% survival. So small changes in pressure, big impact on survival in patients with heart failure, and that was also analyzed for HFpEF and HFrEF separately, where you see the hazard ratio per 1 millimeter of mercury change in pulmonary artery pressure. So it's quite remarkable. So coming back to this, we have a snapshot in our patients when we do an acute right heart catheterization. There's a lot to measure. There's a lot of pitfalls that we should consider. And then if we look more in the long run, we have these tools where we can invasively monitor at least pulmonary artery pressure, potentially more in the future, that is prognostically relevant and that we may utilize more than we do today. And with that, I thank you very much for your attention. Happy to discuss.
Wow. That was a phenomenal tour de force of everything right heart cath related. Thank you very much. I think I will open the grounds for questions.
Thank you so much. Dr. Fatma Hadi, Advanced Heart Failure and Cardiac Transplant Cardiologist from Kuwait. You know, it's a harakat, so I have to talk in this sense. One of the things that you've mentioned beautifully, it's the good, the bad, and the ugly in left heart disease. But I would mention there is another entity which is more even severe. When those patients with chronic left heart disease, they develop RV failure, not just the combined pre and post capillary pulmonary hypertension. And the RV failure in this context outweighs their LV failure. So when you do a right heart cath, it will show as pre-capillary pulmonary hypertension because the RV doesn't generate enough cardiac output to increase the wedge pressure for those patients with left heart disease. And we think that this is a pre-capillary. But knowing the patient's history, knowing that the patient had long-standing LV dysfunction or long-standing HCM, even HCM, hypertrophic cardiomyopathy, with long-standing volume overload, at the end they will die of RV failure. Actually, they will not die with LV failure. And those patients are very critical because it will show in right heart cath that they will have pure pre-capillary pulmonary hypertension, and their diastolic gradient closes, their systolic gradient the diastolic pulmonary gradient closes, the transpulmonary gradient closes, but the key feature here that there is an extremely severe reduction in their cardiac index, and the history tells you that those patients had left heart disease for a longer time. They will be lying flat comfortably, and they will have florid right heart failure. Yeah. And this is a killer, a grave diagnosis, to be honest. But we should be aware that those patients, they cannot be treated with PAH-specific therapy, particularly.
Great comment. I couldn't agree more. And I mean, this is a perfect example of what I said, that we need to integrate hemodynamic measures, imaging, and other things when we interpret the patient's condition and also classify these patients. Thank you.
Stephen, this is more than state of art. Thank you so much. It's amazing talk. It's always nice to go back to basics. Occasionally we see sometimes unexplained high cardiac output measured in the right cath in a scenario where it should not have high cardiac output. Tell me the scenario or the calculation or the sensor, where could be the problem is having abnormally, wrongly high cardiac output in the right heart cath measurement.
Yeah, okay. That obviously depends on the type of measurement. I mean, very simply, what I've seen when you use the indirect FIC is that blood samples get mixed up. It sounds completely trivial and idiotic, but that does happen, and that gives you then wrong values. One thing is also about oxygen supplementation. One thing is about the tricuspid regurgitation and the degree of tricuspid regurgitation. But I should mention a paper that was published many, many years ago by Maris Hüpper. He was the first author on this. It's a JACC paper on the impact of tricuspid regurgitation on the reliability of thermodilution methodology over direct FIC. And it wasn't all that bad. So we always say this, but in the end, it's not necessarily bad. One specific patient subgroup that usually comes up with a true high cardiac output state is the patients with portopulmonary hypertension, frequently having a high cardiac output. And then finally, sometimes we can also see, if we consider the oxygen values, if there is a high cardiac output, then we have high saturation values also on the venous side, because the utilization of oxygen in the periphery is then diminished due to the high cardiac output. Or were you referring to something in addition to that? Had you? Yeah, of course. I mean, okay, get your question. I mean, one source of error is also then the technique, how you do it. You really have to inject it as fast as you can, put a lot of pressure for thermodilution methodology to be reliable. And that also underscores the necessity to repeat it 3 times.
Yes, I think I remember a patient with Dr. Al-Tal'an, a patient that did have a shunt, but it was not to the degree that would explain the difference. So we are obtaining, and the readings were congruent, I believe.
Yeah,
So
but let me just say this. Of course, if the cardiac output is high, it may not be the cardiac output, it may be the pulmonary flow, in fact. So when in doubt, we should do a serial run for oxygen saturations, and we obviously have to rule out a shunt. I didn't mention that.
exactly. Thank you very much.
Thank you so much, Dr. Stephen. If I may have 3 questions for you. The first one about the clinical utility of the exercise pulmonary hypertension looking at the slope. In which situation it will be valuable for us? The second question about the situation where we have the clinical picture is morely suggestive of group 2 pulmonary hypertension, but for example, the patient underwent overdiuresis. Do you think the exercise exercise test is better, or we can use the fluid challenge test or the leg elevation? The third one is I come across the left atrial stiff syndrome. And those patients with the recurrent AFib underwent recurrent cauterization and for the uncontrolled AFib. Some of them, they develop hemodynamics similar to the group 1 with the pre-capillary predominant pulmonary hypertension. So I really want to see your insight about this situation. Thank you so much.
Yes, very much. Now, third part, now I forgot the first part. What was the first question? Someone has to keep track.
Exercise pulmonary hypertension.
Oh yeah, the exercise pulmonary hypertension. Yeah, I guess there are several examples for this. Number one, the nice work that I showed you by Gabor Kovac and colleagues, there was an ERS initiative, has shown the prognostic relevance of exercise pulmonary hypertension as defined in the guidelines. So now you could argue your question is, in what scenarios is this important? Maybe a typical scenario is patients with CTEPD without PH. So we have perfusion defects due to pulmonary embolism. Hemodynamics at resting conditions are normal. And the question is, what should we do? The patients may be symptomatic. Usually in such patients, we see exercise pulmonary hypertension as defined by the slope of pressure over cardiac output change. So that's one example that might help us also for treatment decisions should this patient undergo BPA or PEA. Another example is a young patient that comes in symptomatic, resting hemodynamics are normal, but we have, let's say, pathological cardiopulmonary exercise testing indicative of pulmonary hypertension with exercise. So we always quote that the patients that we see at the time of diagnosis with PAH and IPAH usually are at an advanced stage. So it could be that we see patients that are symptomatic that are not at an advanced stage but feel it, and those might be patients where we are able to capture sick pulmonary vessels at an earlier stage. And there may be, in the guidelines we said that don't treat these patients if they are between 20 and 25 because we don't have data. But if they then, during exercise, show a clear pathological response to exercise, that would be an argument to then treat these patients early on. And I guess we'll learn more over time about the clinical utilization of exercise right heart cath and what to do with an exercise in pressure. So that's this. The second one was... Sorry?
Fluid.
Yeah, fluid. I have to say I'm a bit skeptical with the utilization of the fluid challenge. Why is that? We can do it. We can do it to get more information in the individual patient. I have yet to see any data that tell us if you do this fluid challenge and your wedge rises to more than 18, that these patients will not benefit from PAH therapies. That has never been done. So if I have a patient, there's a certain, let's say, a certain degree of LV stiffness that you also see on echo, but the right heart cath clearly gives you pre-capillary pulmonary hypertension. Patient is symptomatic, I would probably give it a chance, treat this patient. You can do the testing, but the result should not necessarily be don't treat this patient as PAH because we do not I have zero data on this. And I have seen patients that in whom the wedge pressure came up with fluid loading, and they responded beautifully to PAH drugs. So we can do it to characterize the patient's hemodynamic profile, but what we make out of this information, that's questionable in my view. Then the third question was about AFib and a stiff left atrium, and that's important. That's something that we have to consider. Another example of what I said, to integrate our findings from right heart cath and echo, for instance. We can measure LA stiffness in the context of AFib, persistent AFib, but also patients who underwent ablation therapy, because that may trigger a stiff left atrium. So this might be more prominent than we think, and it may have impact on our treatment decision and also the tolerability of PAH drugs. Nowadays, I think we have to refine a little bit. It could be that such patients benefit from a reverse remodeling agent, but run into trouble with the pulmonary vasodilator, a compound that primarily acts by pulmonary vasodilation. So that's something that we have to figure out more precisely. I can tell you that we currently are putting together a manuscript where we have looked at LA stiffness versus mitral regurgitation as a trigger of a high V wave as the component of the wedge pressure. And the result there is that it's LA stiffness predominantly that drives a high V wave as opposed to mitral regurgitation. And we all know that sometimes we have a discrepancy, high V wave, you think, oh, that must be MR. And then you look at the degree of mitral regurgitation on echo, and it's not that pronounced. So LA stiffness also in this context is really important.
Excellent.
So one last question: how to overcome the shortcomings of thermodilution? Do we go for direct fix? And if we over-wedge, do we still get saturation that is near arterial? Mm-hmm. And for how long do you exercise your patients? How many readings during this exercise of PAP and cardiac output do you take?
Yeah, okay.
Thank you. It's always a hot topic. Produced lots of questions.
Sure. So I think how much to exercise, that is, after all, an individual treatment decision, also what the patient is able to do. So I would not have a cutoff in terms of cardiac output. However, related to that, I also want to mention that in the chronic state, not necessarily during right heart cath, a high cardiac output is something that we should take very seriously, particularly if the echo also shows us a hyperdynamic state of the RV. We have learned from the left side that there's a very steep increase in mortality if the left ventricular ejection fraction is above 60 to 65%. So hyperdynamic LV, high mortality. Hyperdynamic RV might also in the chronic state be a source of mortality that we may underestimate. Also when we utilize parenteral prostanoids, what is the target dose? Where do we want the patients to be? I think cardiac output in this context is an important measure to consider. And then I forgot the others. I think thermodilution, how to overcome. I think it's unrealistic to think that most of the cath labs are capable of doing the direct FIC, and we shouldn't really shoot for that. I think that thermodilution is pretty reliable in the majority of the patients. We should be aware of potential sources of error and interpret the data appropriately. But I think thermodilution for the vast majority of the patient is the way to go.
Okay, perfect. I think we are out of time, so we're going to close for questions. But that was amazing. I think many of us have more questions, but that was a phenomenal talk.
I'm still here.
So one last question then. What is your threshold not to wedge? Is there a specific pressure threshold where you just proceed to an LVDP if you have a patient with suprasystemic pressures? Well,
is there a certain threshold? I think, to me, no. There's no certain threshold. I think that we do have patients, we do our very best, and the wedge is 17. But there is no signal of left heart disease, and everything else is, every other information that we have is towards PAH. I would probably still label this patient group 1. And vice versa. There may be patients with clear signs of HFpEF, a large left atrium. We have LV hypertrophy, patient has AFib, and it's clearly a phenotype of postcapillary, and the wedge is 14. I would probably label this patient group 2. When should we measure LVEDP? I guess whenever we have the feeling it's technically not possible to get a proper wedge. That's when we should do that. In this context, I just want to argue that what we really want to know is the wedge and not the LVEDP. We sometimes say that wedge is measured as a surrogate of the left-sided filling pressures. That's not really correct. We want the wedge. That's the first thing that we really want because it gives us different information, and there may be a difference between the left atrial pressure and the wedge. That's a true difference, but that's what we want to know.
Perfect. Thank you very much, Dr. Rosenkrantz. Excellent talk.
Well, I think it was really very long. So we have 5 minutes to stretch legs and go to the bathroom, and we'll come back.
Assalamu alaikum. So we can start our next workshop. Okay, I will go ahead. Okay, so it's my pleasure to introduce Dr. Stian Grain from Ireland, who is a consultant pulmonologist and expert in pulmonary hypertension. He will give us a talk about risk stratification in pulmonary hypertension. He is a friend of SAPH. He needs no introduction. We're all looking forward for his talk.
Assalamu alaikum as well. And thank you, Dr. Gbasi, for the introduction and for the invitation again, Professor Adalan. It's a great pleasure to be back. And a new change for Jeddah instead of Riyadh. I enjoyed the beach this morning. Professor Adalan will know that in Ireland at the moment we don't have sunny weather or beach weather. Wouldn't that be fair to say after your trip to Dublin? So listen, I'm going to talk a bit about risk stratification. And you know, risk stratification, just to start with, I think it's important to say that risk and management, that was the title. Risk and management go so closely together. When we look at the World Symposium approach to risk stratification, we can see that the first thing you do at the first initial visit is you risk stratify before you can make a decision about how you're going to manage that patient. And similarly at the first follow-up visit and subsequent visits. So the two of them go hand in hand. And that's why it's vitally important that we get the risk right in the first place. But what I wanted to do was put a little bit of pragmatism into risk stratification. And I'm going to start with a patient of mine. This is a patient, Karen. She, and I've shown you here, here's her chest x-ray from 2004 and a subsequent one from 2022. And just to tell you a little bit about her, because she presented after the birth of one of her children a few months afterwards, and she came having read on the internet about pulmonary hypertension and idiopathic pulmonary hypertension. She knew her life expectancy was around 2 years. She went on to have her initial risk stratification. She then went on combination therapy to begin with. And the first follow-up visit, it was quite clear she was doing poorly, and then went on triple combination therapy with a parenteral prostacyclin. And the rest of her story goes on until she subsequently deteriorated, needed a transplant, but then developed complications of pulmonary hypertension when you get that far out. She had atrial arrhythmias, she had renal problems, she became quite vulnerable, ultimately was delisted and passed away and died about 2 years ago. So the reason I show you this picture of her story is she went to the press and she announced and she wanted to increase awareness about pulmonary hypertension. And she wrote this article, and in it really was, "My heart is getting very tired, I need a transplant, mother of 2, hoping for a brighter future for her family." And it was that notion of her heart getting tired that really pressured her to know that drugs weren't going to work anymore. She now needed transplantation. But if you look at this, if you think about risk stratification, I would have done risk stratification in her case about 70 times, right? She lived for 18 years. She came every 3 or 4 months to clinic. We'd always see her do a walk test, evaluate her, look at her BMP, and we'd have done a lot of risk stratification. But ultimately, there were only 3 occasions where that risk stratification was vitally important. The first one, the first follow-up visit, and when we decided ultimately that she required transplantation. And a lot of the time in between transplantation or risk stratification, I think, can become a distraction to the more important thing of observing the patient, examining the patient, and talking with the patient. And that's what I wanted to say about pragmatism. In fact, just to give you another example of where risk stratification can sometimes, I think, be, again, a distraction. This is Karen's CT. And you can see the size of her right ventricle, the size of her right atrium is squishing her left ventricle. Everyone would look at this and say, that's a high-risk image. That's a high-risk case, okay? But actually, at the time, she was functional class 2. She was a very positive lady and worked away with raising her children. Her walk distance still remained within the intermediate low-risk range, and her BMP, in general, didn't go into the darker ranges until close to the very end when she got the renal insufficiency and renal failure. So she was actually intermediate low risk with that image, and it just goes to show you that seeing is believing. You really do need to take more time at the bedside and look rather than just look at numbers. And in fact, that brings me to the notion of bedside approach to pulmonary hypertension and not forgetting the patient. And this is Sir William Owsley. You all know Sir William Owsley, was born in Canada. Then he went to the United States, was in Philadelphia and in Johns Hopkins, and then came to the UK and was knighted and was in Oxford. But he had a lot of great quotes. And one of the quotes I think that brings us around to risk stratification is this one: medicine is learned by the bedside and not in the classroom. Let not your conceptions of disease come from the words heard in lecture room or read from the book. See and then reason and compare and control, but see first. And that notion of seeing first, I think, is really important when it comes to risk stratification in our patients. Okay, so let's see how we can think about how seeing the patient will help us with risk a little bit further. So how we go about risk is really a combined assessment. It's not just getting a bunch of numbers from non-invasive evaluation or looking at hemodynamics and taking that on its own. It is a combined assessment. There's clinical assessment, the history, the exam, ancillary tests. There's clinical experience, intuition, gestalt. We'll talk about gestalt in a moment. And then there's the validated risk assessment tools, the ESC/ERS guidelines, French, Swedish compara approaches, adding up numbers and coming up with risk, and then the reveal that's used a lot in the US. But here's the important thing. When you actually look at it, these multi-parameter risk assessments, they're only used by about 6 out of 10 physicians in the US, and they cite reasons for not using them, such as it's not on my electronic patient record, I don't really have the time, I can't get all the numbers together on a regular basis. So it's not used as much as it should be. And the other comment to make is the gestalt. You know, this notion of gestalt, it's your intuition, your feeling about a patient, but it gets it wrong a lot of the time too. More than 50% of PAH patients who with functional class 2 symptoms were classed as having intermediate high risk using objective multi-parameter assessments. So we often think our patient is doing okay, but when we go and look a little bit further and do multi-parameter risk assessment, it's not as good as that. And in fact, some of you will be familiar with this particular study that looked at what does Gestalt do. And what we know is Gestalt is good when patients are intermediate risk. But when patients are low risk, we tend to get it wrong. And in fact, 80% of the time, we get it wrong. We're thinking they're low risk, but in fact, they're not. They're worse than that, 80% of the time. When it comes to high risk, we say they're high risk. 30% of those patients are high risk, but actually 70% of them are not high risk. They're a little bit less bad than that. But the intermediate risk we get generally speaking, reasonably well. So Gestalt, your own personal feeling and intuition, needs extra help to be valid. So let's go through a few of the reasons why this whole idea of risk assessment is fraught. It has its problems. It always doesn't necessarily give us the right answers all the time, and why we need to really have this a more composite approach. One is the patient. No two patients are the same, be it age or gender, be it whether they have heritable disease or not. Heritable patients do worse than those who haven't got genetic manifestations. Comorbidities can make the disease worse. Physical fitness levels. If you're very fit and active before you get diagnosed, you're not going to do quite as well as somebody. You're going to pick up the disease a lot quicker than somebody who doesn't. And then many behavioral aspects change the way the disease affects a patient. There's the disease itself. The disease and PAH can be very heterogeneous as well. No two patients or no two manifestations of PAH in patients are the same. Incident versus prevalent patients, very different. Response to treatment can vary. Comorbidities affect risk and response to treatment. And connective tissue disease, for example, those patients do less well, and then the patients with congenital heart disease do better. So there's a huge heterogeneity in PAH alone. And then what about the doctor? I think the doctor is a really important one. There's heterogeneity in doctors as well. In the doctors, the specialty can change things. When you are a cardiologist, you'll be very happy to look at your echo and to look at your hemodynamics. But if you're a pulmonologist, you'll be much happier to look at your imaging and to look at your lung function. And so there's a difference in how people interpret and decide on where that person's risk is. So there is that heterogeneity across both. And finally, there's the tools that we use. There are actually too many risk tools that we have to use to try and find what's going on. So it's becoming more accurate, but more complex. Non-invasive parameters are very useful and a very good basic first step, but they're not disease-specific. Echocardiography is great, we know how important it is, but it needs to be focused. And it also needs to have more simplified RV measurements and so on. I mean, we get as pulmonologists a long letter from a report on an echo, and you're thinking, which of these parameters am I going to focus on, and which of these is really telling me what's happening? So it's important that we simplify that. And then finally, cardiac MRI is very good, but it is costly, it is not available everywhere, and it still needs to be interpreted. So those are the reasons why, and we come up with this. This is for your initial assessment. We see all the different parameters. There's clinical evaluation, there's exercise capacity, there's RV function. There's so many different things that we have markers that give us an idea where the person sits in terms of risk. But we need to remember that there's so many that are not there. Age is not there, male sex is not there, because they do worse. Incident and prevalent do worse. Current PAH treatments doesn't figure in. Diffusion capacity, really bad prognostic indicator, doesn't figure in. Whether you have connective tissue disease or PVOD doesn't figure, and yet it'll make a big difference to the outcome of your assessment. Now, I like this particular image, and I often use it as a way of explaining how difficult risk stratification is. It's from the Dutch group, and what they did is they took their patients and divided them into patients who they described as having a favorable outcome. Those are patients who lived longer than 10 years, and those are the ones in green. And patients who didn't do quite as well, who didn't survive as long as the 10 years. And you think, what's the difference between them? Well, if you just did non-invasive evaluations of these patients, you'd see the 6-minute walk distance really didn't change much until towards the end and wouldn't have helped you distinguish between those two patient groups. On the other hand, if you looked at their MRI, and I would say if you looked at their echo, or if you looked at any way of imaging that right heart, you would have seen that the patients who didn't do so well, the ones in red, their end diastolic volume started to increase very early on in their course. And their ejection fraction didn't improve like the ones who had a favorable long-term outcome. So those are two things that are almost like underneath the tip of the iceberg that are available to us to know if the heart is dilating early on, it's maladapting and the patient is going in the wrong direction. And if the ejection fraction doesn't improve in response to treatment, those patients are going to do poorly. But those are things that you might not get just from checking the functional class. You may not get it from checking the walk distance. You might pick up manifestations of the dilation from your BNP, but it may be influenced by many other factors as well. So we'll come back on this figure again in a moment. Now, our French colleagues decided, well, look, with that piece of information in mind, hemodynamics makes a big difference. And in fact, you can go much more granular if you start using hemodynamics. And so here you see, they say, look, at the first follow-up visit or a follow-up visit, you can say patients are divided into the 4 strata, okay? But if you then look at stroke volume index or the pulmonary artery saturation, you can actually end up by dividing patients even again. So you can go from intermediate low risk into 2 different groups and intermediate high risk into 2 different groups. And it's actually very helpful because you can see that 3-year survival goes from 90 to 80 to 70 to 55 or so, 40 and 20, just by using the stroke volume index to break those up. And that goes back to that image where you can see that if the ejection fraction is improving, you're going to do well. If it's not, you're not going to do quite so well. But again, it's quite complex. So that's where we bring it there. But if I might, I think that seeing is believing, and we go back on that idea of first, see first is what Sir William Osler said. And Roberta's here sitting, knows this work and really made, I think, a really important discovery for us. And that is, and from our Italian colleagues, is that you can actually look at the echo and look carefully at the echo and stratify patients into 4 strata and their phenotype. Let me go through this for a second. So the lower risk group that are here have a good TAPSE. The intermediate low-risk group here also have a good TAPSE. The only difference between those two is you're getting tricuspid regurgitation here. The heart's starting to dilate. You're getting the earliest manifestations of maladaptation. On the intermediate high risk, they've got a low TAPSE, as do the high risk have a low TAPSE. But what really distinguishes those is you're starting to dilate up your IVC. So the full manifestations of heart failure are beginning to become apparent. And this form of phenotyping using TAPSE, tricuspid regurgitation, and the IVC outperform traditional echo measures, such as the right atrial size and whether you have a pericardial effusion. But it's bringing you to the bedside to look and see, and see where your patient is when it comes to the pathway of pulmonary hypertension. And in fact, they've done a little bit of more work on it. By the way, all you're really doing in many ways is you're looking at the images I showed you earlier. You're seeing, is the patient staying fairly static or are they dilating? But this is another way they've done that phenotype that I really like. There's 4 phenotypes again. And really the distinguishing feature between the first 2 and the second 2 really is whether you're beginning to dilate fully or not, and the RV getting bigger than the LV. But phenotype 1, they say mildly dilated right ventricle, preserved PA or RVPA coupling, it's your TAPSE-PAPSE. Phenotype 2, mildly dilated right ventricle, but poor coupling. And then on the group over here, you see severely dilated right ventricle with preserved coupling, or severely dilated with poor coupling with or without tricuspid regurgitation. But you can actually do that at the bedside. And I'll make the case to you that if you look at point-of-care ultrasound, or an echo at the bedside, or a CTPA where you could actually make an estimation of what your RV-LV dimensions are. And you can divide your patients straight away into the phenotype 1 and 2, or the phenotype 3 and 4. And then if you get a BNP, you can decide whether they've crossed over that line to a more significant degree of dilation. And you can even throw a stethoscope on a patient at the bedside too, and ask questions about their tricuspid regurgitation. So it's just the notion of bringing risk stratification closer to the patient where you observe rather than just looking at numbers. So let me go to a couple of cases that I think just show you some of the problems that we face in risk stratification and how we have to use more than one tool to do that. So the first one I thought I'd share with you was one where Gestalt can augment risk stratification. Not on its own, but it can augment risk stratification. So this is Louise. She's a 30-year-old lady, previously generally fit and well. First noticed dyspnea on the birth of her 3rd child. She described slowly progressive over the following few months. And after several visits to her general practitioner, she was referred and admitted to her local hospital. She was sick enough when she presented. Not that different to the story of Karen that I mentioned at the beginning, presenting after pregnancy. No past medical history, no medications. She did have a family history to suggest heritable disease. She had a cousin who had died at a young age of cardiovascular disease. She lived with her husband and 3 children, worked as a teacher, and did smoke for a period of time. On presentation, blood pressure was a bit low, 105 over 70, heart rate a bit high, SATs were okay, BMI okay, cardiac exam, JVP around mid-neck, and she had a prominent P2, an S4, and she didn't have any tricuspid regurgitation. Lungs were clear, mild edema, but no evidence for scleroderma. HIV negative and ANA negative, normal spirometry, diffusion capacity okay. Her chest X-ray here, you can see mild cardiomegaly, PA is a little bit prominent, no infiltrates, VQ negative. And her echo report, and again, this is where I mentioned earlier, as a pulmonologist, I got an echo report that really quite succinctly stated that the LV function was okay, but there was septal flattening, and that the RVL and RA were severely dilated with systolic function moderately reduced, with an RVSP of 90. So we did a right heart cath, and you can see here, when I look at a right heart cath, I would say, well, do they have pulmonary hypertension? They absolutely do. 104/31, mean 58. Is it pre or post capillary? It looks pre-capillary with a wedge of 12. And then you ask, well, how's the right heart dealing with that? And the right heart, right atrial pressure is significantly elevated, and cardiac index is down a little bit. It's not the worst that you could see. She's pre-capillary, confirmed. And the initial suspicion was that she had IPAH. It fitted everything for IPAH, but she could have HPAH. She could have heritable based on her story. And so when we did the risk stratification on her, you'd have to say that it really looked like she was intermediate, or what we would now say is non-high risk or not high risk, given the functional class 3 symptoms. Walk distance was 410, BMP 280, and then her hemodynamics as mentioned. I would say, though, that when it comes to gestalt here, my gestalt on the case would be that it was actually more high risk. And I might, for a moment, just take a pause, and maybe we can stop our people and ask questions where people think this does fit easily into intermediate, not high risk, or high risk for initial presentation in this young woman. Is there anyone here who would say that she is high risk? Are we happy enough with the measures? And I'll tell you why I said high risk from a gestalt perspective. Was young woman, walk distance 410, it's not great. Her echo showed a severely dilated right atrium and right ventricle. There were a number of factors that just made me nervous. The heritable disease, heritable is worse in general. So a number of those things came together, and she's a young woman with a young family, and treating early and aggressively makes sense. So gestalt was high. Anyway, we treated her with double combination therapy, as you do in the situation with somebody who's non-high risk. And she came back and she improved, as you'd expect with double combination therapy. She had a nice improvement. You can see she'd gone to function class 2. Her walk distance had improved to 505. BMP was down very nicely with diuresis and therapy. And her hemodynamics had also improved. We did a follow-up right heart cath in her, and you can see that, if anything, her PVR had dropped from 11 to 7. So the question would be, is there any requirement here to escalate first follow-up visit in this young woman? Again, I mentioned to you, but my gestalt, I wasn't happy because of her age, her possible heritable. I didn't like that echo. Is there anything else that you'd want to make a decision at that first follow-up visit about what to do next? You have everything you need. Well, actually, in this particular case, I bring her up because if you look deeper into her case, and what we did in this case, just to do a reveal, just look at her risk stratification from a different angle, use a different tool to risk stratify. And if you do that in her case, you find that, in fact, she comes out at high risk to begin with. And she comes out high risk because she had low blood pressure and tachycardia when she presented. And she also had to be admitted. And if you put those things into reveal, those are worse prognostic indicators. And in fact, for a young woman in that situation, it might have made sense for her to have gone on triple combination therapy, including a parenteral prostacyclin, as a young woman in that setting. The danger of double combination therapy in that situation is that actually people respond remarkably well to it, and it puts them into somewhere better, but it's a false sense of security. Interesting, when we treated her with the double combination, she dropped, but she didn't drop into low risk as we had thought. She dropped into intermediate when you do the reveal registry. So she still doesn't fall in entirely. Her pressure remained low, and the hospitalization had come into place still for that reveal. So her case summary, she's idiopathic. In fact, it turned out she was heritable ultimately. We did get back her gene. She was calculated as not high risk, and therefore she was only a candidate for double combination therapy. She then went down to low risk based on the normal approach to risk. But if we look at this case more carefully, she really was probably high on Reveal to begin with, and she only went to intermediate on follow-up, and she probably then would have benefited from treatment escalation at that first follow-up visit, rather than leaving her sit on double combination therapy for another year or two until she really starts to dilate and starts doing all of those nasty things that we saw that the echo does over time in risk stratification. So I'll stop there for a second. Does anyone have any questions about that particular case or want to add any comments or anything about her? And I use her as an instructive case on having to use, it's not just a black or white that you say this person is high or low or whatever it might be. You have to take everything, and including your intuition, including your Gestalt, including data that comes from other sources. Reveal uses different sources. It looks at things that are not actively seen, such as how the patient is doing from a blood pressure, from a renal failure, from a hospitalization perspective. And it will change the way you might stratify that patient. Okay, I'm going to go on to the second case. And this one is a case that I wanted to raise because I wanted to point out that risk needs to understand the patient. I'll explain that to you in a moment. So let's have a listen to this patient. So she's a 74-year-old woman. She had Raynaud's phenomenon noted about 10 years ago, 10 years prior to her diagnosis. She was diagnosed ultimately with systemic sclerosis by her general practitioner. And she first experienced dyspnea early in 2016 while on holidays abroad. And she was a smoker and felt unfit. So that took her a while really to work out that she really had a pathological cause for her breathlessness. She described the breathlessness as slowly progressive over the following year. But she also, as a note, she had deteriorating renal function as well that went along with her systemic sclerosis. After several visits to her local doctor, she noted a more abrupt decline, and she was referred to her local hospital with chest pain dyspnea. And I say low mood as well, and that she was a history of depression, and her change in status hadn't helped. So when she came, she was tachypnic, temperature 37.5, blood pressure 110/70, heart rate 90, saturations in room air 94%, JVP was at mid-neck, S4 but no tricuspid regurgitation again, diminished breath sounds but no crackles or wheeze, and she did have 1+ edema and some sclerodactyly. So what I would say is a rather typical CREST systemic sclerosis type patient. And she was an ANA positive. She was anti-centromere positive. Her NT-proBNP level was up. It was actually higher than that error there. Her GF4 was down. She had significant renal dysfunction. Her lung function, she had okay in terms of spirometry and lung volumes, but she had a low diffusion capacity, again in keeping with her systemic sclerosis. But the chest X-ray had no infiltrates, and again had just some cardiomegaly. VQ okay. But look at her echo report, LA size, LA normal size, which is important in an older woman to make sure she doesn't have LV dysfunction. But the left ventricle appeared normal except for some mild septal flattening. And in contrast to the last lady, this one had only mildly increased RA and RV, and the systolic function only mildly reduced, RVSP of 60. So she went forward for right heart catheterization, and again we'd ask, does she have pulmonary hypertension? She does. Is it precapillary? Yes, it looks like that. And how's her right heart dealing with it? Better than the first case. She does have a better cardiac index and mixed venous oxygen saturation and right atrial pressure. So precapillary confirmed, and initial suspicion, as you can imagine, this was PAH associated with systemic sclerosis, the CREST variety, ANA positive and anti-centromere. So if we look at her, and we look at her overall initial assessment, she'd fall comfortably enough into the intermediate, not high risk category for double upfront combination therapy, you'd say. Function class 3 in her symptoms. 6-minute walk distance was poor at 280. I'd mentioned her BNP was higher than we had estimated there. It was actually 1,000 at her initial presentation. Right atrial pressure 8, index 2, and mixed venous 64. So she falls neatly enough into that intermediate. She's certainly not somebody that you'd be worried about from a high-risk perspective and requiring parenteral prostacyclins, and particularly in light of her comorbidity and an age, but still, that's where she sits. My gestalt will be the same, that this is somebody that we are getting midway on the clinical spectrum. So admitted to the hospital, diagnosed, and given that intermediate or not high risk. But when she came back for her first follow-up visit, it was interesting. So if you look at her, she was still functional class 3. She felt that the medications had done her no good, that she didn't improve. She remained with a low mood, was very upset by the change in her health status at this stage in her life, and with her scleroderma, but now with her dyspnea, and now being told that she had pulmonary hypertension and requiring new medications. Her walk distance had improved, but still was nowhere near as good as you would like to see it. Her BNP had improved from what she had seen before, of around 1,000. But remember as well, she did have renal dysfunction. So overall, she was now intermediate high risk, if you look at her numbers. But here's the interesting thing. If you just took, based on those numbers again, she's intermediate high risk, and in the absence of sotatercept, you'd look at her and say, well, maybe this woman needs to be considered for parenteral prostacyclin, for example. She's not doing well. But if we look at her echo, she now had a TAPC greater than 17 and normal RV function noted. And in fact, if we go to Roberta's image, she fits in nicely into that low-risk phenotype from the right heart of a good TAPC and no tricuspid regurgitation of any significance. So we sent her for a right heart cath, and her right heart cath showed that she did have a robust response to medical therapy, which isn't what she felt. Her PA pressure had come down some, her cardiac index had improved substantially, including mixed venous saturation, right atrial pressure down, and her overall pulmonary vascular resistance was down by approximately 60% of what it had been on double combination therapy. And we do sometimes see that in patients who are really robust response. But if you were to look here for a moment at what we see with the non-invasive approach, taking her functional class, it didn't change. Her 6-minute walk distance did improve, but it was still in an intermediate categorization. BNP had dropped, but it still wasn't normal. Her hemodynamics, however, had done remarkably well. And so this was a lady, I think, that it would be fair to say that at 75 years of age, with scleroderma, with a history of depression, with renal dysfunction, using a non-invasive approach to looking doesn't take into account fully the woman that's sitting there in front of you in the clinic. And that's why sometimes you do need something that's more concrete and more objective to decide before you decide to escalate treatment further. And so was there a requirement to escalate based on non-invasive? Yes, there would be, but based on a mixture of gestalt, we're happier, given her age, her low mood, her EGFR, and her good initial echo and subsequent echo, you'd have to say that she's somebody that risk needs to be interpreted in light of those. So she was PAH, as we mentioned, not high risk to begin with. Calculated risk remained intermediate high, but actually her follow-up risk, when you look at it and take everything into account, is substantially better than that when we looked at her overall clinical picture. So if we go back to Sir William Osler, if I might, and think about Sir William Osler's approach, I would say that non-invasive risk stratification with contemporary risk scores serve as a useful basic assessment of disease severity. And it does predict survival, but it's well used, most useful in the setting of large population groups and looking at, rather than the individual patient that's sitting right in front of you. Simple imaging measurements echocardiography, POCUS, even looking at your CTPA. We heard from the earlier talk this afternoon. It can be very helpful just looking at how the right heart is looking, how the right atrium is looking on a CTPA, and giving you a feeling, a gestalt for where your patient is, just based on that image alone. This non-invasive approach, and you incorporate that along with your risk stratification, I think requires further evaluation, because I think it's looking and seeing the images is crucially important. Bringing risk assessment back to the bedside and using your gestalt will have broader global applicability than increasing the complexity of our approach in routine practice. We can make risk stratification way too complicated. And as I mentioned, my first lady back when I taught Karen, we did over 70 risk stratifications on her. When you think about it, that wasn't what was required. So let me just finish up by going back to that initial quote. Medicine is learned by the bedside and not in the classroom. Medicine is learned by the bedside and not just with risk scores. Let not your concepts of disease come from the words heard in the lecture room or read from the book or measured on a calculator. See and then reason and compare and control, but see first. And seeing then is believing. And I'll leave you with that thought, and be happy to take any questions.
Thank you. That was, as usual, a great talk, Dr. Gain. Now the floor is open for questions. Yes, Doctora, go ahead.
Thank you so much. It was very brilliant and outstanding, as usual. So my question is regarding the risk stratification. It always doesn't make sense for me applying a fixed value numbers to all of the patients. So for example, young, as you brought the case, young female, she should walk more than 400, and if she walked 400, this is probably 50% from her normal predicted value. For example, elderly females, we have a lot of elderly patients with a lot of comorbidity, for example, osteoarthritis, some of them in wheelchair. You cannot ask them to walk. And even some of them, if they walked, their baseline will be 200, 300. So let's say this 300 or 200 is 80 to 90% from their normal predicted value. So it doesn't, make me thinking more practically about the values rather than what do we think if we can apply percentage from the normal predicted value for those patients. Also, I have a question regarding why up until now we didn't add the echo parameters as a follow-up risk stratification for our patients, rather than depending only for the WHO functional class and BNP and 6-minute walk test. Thank you so much.
Thank you. I think that is a really good and very practical aspect about life, is that every patient who comes in is very different in what they can do. If you get somebody who's been an athlete all their life comes in doing a 6-minute walk or something is a challenge for them, they look forward to it and they push it, and they almost syncope trying to get the best result. And then you've got somebody that you mentioned there who really is a bit more elderly and doesn't look forward to coming in to do the 6-minute walk and gives it and underperforms on it, and you're trying to make decisions on that. So I'd say that's why I think by itself I think we sell the message incorrectly to focus too much on the non-invasive. It's useful. It does. You can see this, the Kaplan-Meier curves that our French colleagues were able to show us that occur depending on where you stand on the non-invasive approach. But when real clinical management, I think you'll see far more when you sit at the bedside, hear how they're doing, and I think imaging is an important part of that. The real message there is that the heart dilates. When it starts to dilate, you're in trouble. And if you're not looking for the heart dilating and you're only looking at the non-invasive things, you're not fully getting a comprehensive look at the patient. And I think that what our Italian colleagues have talked about, getting the phenotype of the heart, I think it's a very useful bedside tool to look and see how does that heart look? Is the heart dilated? You might not know looking at the patient that the heart's dilated. You might, by listening and hearing an S3 galloping, hearing a wide open TR. But unless you're looking, you will miss a heart that's beginning to strain. And once it gets to that big size, the patient may still be function class 2. They may still have a reasonable walk test if they're young. The BNP will be on the way up, but they're really vulnerable. One pneumonia and they're gone, or one small added event, a need for surgery, and they're gone. So a big heart can deal with a lot, but it is a very vulnerable heart, and we're not really looking at that.
Yes, doctor, you have a question? Or
Yeah, so just a quick, thank you very much, Sean. Again, a brilliant approach to a very common problem. I just want to say that the gestalt in experts' hands is a little bit different than, it's not easily translatable. I think this is one of the dilemmas we have. You've probably seen thousands of patients, and I think you can see that path literally from the first visit. So in your trainees and the people that you're training, how do you actually make that more, should I say, concrete? I think this is where this over-reliance on these numerical assays has become popular, but how do you pull out the Osler-like clues? You have to be with Osler to be that, but you're very close.
Well, no, I think it's important to emphasize that, because you're right. I mean, Gestalt is different to the young trainee arriving, which is why the non-invasive approach is really helpful benchmark to have for people. But I would encourage people to go, there's your base. That's your scaffolding that you're building your analysis of your patient on. Now, at the bedside, what did you make of that? And hearing an S3, for example, in somebody who's coming out non-invasive, that's all fine. Something's up. I mean, that at the bedside, or the neck veins are popping out, and you look at everything and it looks fine on non-invasive. BMP is just a little bit high. So I do think that there has to be a safety blanket, and I think what we describe here in risk is a good safety blanket to start with, but it can't be taken on its own. And that's why I think Reveal is helpful, and it allows us to go that little bit deeper at times, pick things out we mightn't have otherwise thought about. But I think most importantly, and I think cardiologists have this, you have the ability with echo at the drop of a hat, but pulmonologists often don't have that ability to go to the echo and look at the heart. And until we start doing that, I think pulmonologists are going to be coming at it from a slightly weaker perspective when it comes to looking at overall risk.
Yes, doctor, go ahead.
Hello, Prof. How are you? So just a quick comment there. In terms of the 6-minute walk test, okay, how well do you think we are looking at it? So we are looking predominantly at the distance. We're not paying a lot of attention to the saturation drops, to the heart rate. So if we take that into consideration, especially in younger patients, you would expect them, if they were relatively well enough, they can actually give you the distance, but you will probably notice the tachycardia, you will notice the desaturations, but these are not being taken into consideration when we are applying most of the scores. Yeah. So,
no, I think that's a great comment, Noah, and you'd know from your time in the Mater Hospital that our walk distance, it has to, isn't actually the right length of corridor at times. And so there are many things that figure in. But what you said is absolutely right, that 6-minute walk is a very valuable tool, and we take one number at the end of it. But it's well known that if you take some other parameters, be it, as you mentioned, heart rate, your SATs, your Borg, those things can all add to it. And give you that feeling. But sometimes you'll see that when the patient comes into your room and you look down and the nurses will, or whoever's doing your walk, will have jotted in some comment even. Because you weren't there, you didn't see it, and it might be a comment pre-syncopal. I mean, that's important. So I think when it comes to walk, very valuable, it's a useful number, but there's so much more information that can be gleaned from that. And as clinicians, we need to be receptive to that and be listening out for it. But yeah.
Okay.
Hello. So being a heart failure physician, I would like to ask because in risk stratification, we do have 6-minute walk tests, NYHA classification, and NT-proBNP, but oftentimes we miss what is the patient taking concomitantly with his PAH-specific therapy, namely diuretics, like high-dose loop diuretics, thiazide-like diuretics. Someone with a low-risk, category on a high-dose loop diuretics is not similar to someone who's not taking any diuretic at all. And this is what I find that is often missed from many physicians, where someone who's on a torezomide of 60 milligram BID in a low risk category, he's not the same as someone who's not taking any loop or thiazide like diuretics. So, and I often find that the patient who takes high doses of diuretics, they have a high risk hemodynamic parameters, even though they are at a low risk 4 strata category. So what's your take on that?
Yeah, I mean, it's a very good point that we don't really take it into account. You know, do we? You know, and so if you take a cold, a patient coming in before you've even started to treat them, are very, very different in appearance than when you've got their BMP down and you've got their right atrial pressure down, and all of a sudden you're in a better position to treat them. Whereas somebody who's maxed out on diuretics is in the same position is very vulnerable and may already have deteriorating renal function, and so actually the room for maneuver is different. I think those are all part of that gestalt and that bedside feeling about the patient. How vulnerable is that patient? Just because all the numbers look well doesn't mean that they're safe, and it may mean that they're not capable of facing even the smallest change in their clinical status. And I gave that example of surgery is probably the best one. We often get asked by people, is the patient fit for surgery, or can your pulmonary hypertension patient have surgery in an outside hospital? And the answer to that generally is no, they can't. But there are some who are, you know, are doing well, low risk, not on diuretics or on very mild amount. But somebody who is on maximum medical therapy and still keeping a relatively low risk is not safe in anyone else's hands except yours.
Okay, I think we are really grateful for this talk and for the people in the task force who did the risk stratification. How do you see the future of risk stratification, and are there any elements or tools that are going to be added?
Well, I would say that two aspects that I have a longer term hope would be that risk stratification would be something that we'll need less of, because we'll have therapies that keep people in a very good place, and we'll once we make that decision, patients can get on with living their lives rather than being continuously reassessed. That'd be my longer term goal on it. I think if I had a shorter term goal on it, would be to really move towards imaging and looking at the right heart and see where it is along the journey, rather than just looking at numbers. And so that's why I particularly like what Roberta and our Italian colleagues have done, is really begin to show us what a right heart looks like when it's going through the journey of deterioration in pulmonary hypertension, and don't miss the opportunity to keep it in a good place, or reverse remodel it to bring it in a safe place. Because if you do that, you can let your patient go and live their life. But so my longer term, we hope we won't need as much risk stratification in the future. But for while we do, we need to get better at looking at that heart.
Thank you. Thank you for finishing on time. Dr. Dalan, are we going to do an announcement about the... Okay.
Thank you very much, everyone, for...
Thank you.
Just remember that we will have a break now for prayer, and we should be back 5 minutes before 7 for the official opening and 2 state-of-the-art keynote lectures. Okay? 5 minutes before 7. Please be back. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. On behalf of my colleagues and staff members, I welcome you to the 13th annual meeting.
Welcome to our 11th SAPH meeting. SAPH is the Saudi Association for Pulmonary Hypertension. It's a specialized group of elite physicians in Saudi Arabia and including some of the Gulf region.
Saudi Association for Pulmonary Hypertension meeting, SAPH 2018. It was just held here in Dubai in April 2018. It's been actually a great meeting. I've had a chance to interact with some of the leaders in the field.
Every year this Congress is providing the best possible knowledge and evidence for the different treatments in any area, including drugs, including interventional procedures, and including also surgical procedures.
Diagnosis, prognostic and risk factor differences between idiopathic and chronic diseases related.
As I'm part of the SAPH family for many years now, I like to come to this conference year by year. The organization, as usual, is perfect, and the quality of the scientific program is outstanding.
We have more than 500 patients included in this different trial, meaning a lot of small trials, and we have the AIR study that are nicely showed in the previous meeting.
We're grouping many people from different countries, and from Europe, from the US, and from Saudi Arabia, and Dubai, and many other countries.
Many colleagues that really worked very well. From the international speaker, I really need to say that the PBRI had a great role in SAPH success, so I'd like to have basically special thanks.
All the experts in the field, get all the updates, and get to know your colleagues and mingle with them. SAPH is an amazing team, which we are really proud of, and I hope it will continue for years and years to come.
ضغط الدم داخل شرايين الرئة وليس الضغط العام. وبما أنه يرتفع ضغط الدم داخل شرايين الرئة والقلب تدفق الدم من الجهة اليمنى من القلب يدخل الرئة. فإذا كان هناك ضغط عالي في شرايين الرئة يأثر على عضلات القلب بالذات الجهة اليمنى مع الوقت.
نعم ممتاز. طيب هل هو يعتبر مثل ما ذكرت في البداية أنه هل هو مرض نادر وهل تشخيصه سهل؟ وبرضه يا دكتور يعني كيف تشوف طريقة علاجه؟
هو طبعا نادر لكن لها أسباب كثيرة، بعضها شائع وبعضها نادر، وهو يصنف إلى عدة مجاميع.
نعم.
هناك ما تسمى المجموعة الأولى وهذه هي اللي نادرة، وعادة يعني بالطروحات والنشرات العلمية
نعم.
تقريبا بين 50 إلى 100 كل مليون يصابون في هذا المرض.
نعم.
وهو طبعا بحكم أنه نادر وبالتالي يكون تشخيصه في العادة صعب شوية. وعادة التشخيص يعني يتولى عملية فرز أسباب المرض، لأنه هو صحيح المحصلة هو ارتفاع ضغط الشرايين الرئوي، المحصلة النهائية، ولكن لها عدة أسباب. فدقة التشخيص تكمن في فرز هذه الأسباب وبالتالي وصول التشخيص الدقيق وبالتالي أيضا العلاج الدقيق، لأن لكل مرض لكل سبب من هذه الأسباب علاج.
الاستوديو رئيس الجمعية السعودية لمرض ارتفاع الضغط الشريان الرئوي الدكتور عبد الله الضلعان. اهلا بك دكتور عبد الله، مساء الخير.
اهلا وسهلا.
دعني ابدا معك في البدايه عن تعريف يعني بهذا المرض.
الريبورتاج المقدم لخص المرض لكن ببساطه تعريفه هو ارتفاع الضغط داخل الشرايين الرئويه وليس الضغط العام للجسم. وكما هو معروف ضغط الشرايين الرئوية دائما يكون قليل جدا ليستوعب تدفق الدم من القلب. إذا بدأ ارتفاع الضغط بدأ يأثر على القلب وبالتالي تتعب الجهة اليمنى من القلب عادة. طبعا له أسباب كثيرة يعني ما أظن هذا مجالها، إنما هو يعني بشكل أو بآخر يعتبر مرض نادر. تشخيصه يحتاج دقة في التشخيص، وعلاجه أيضا يحتاج دقة في لأنه هو أكثر من مرض أكثر من مسبب والنتيجة واحدة اللي هو ارتفاع ضغط الشرايين الرئوي. ولذلك احنا في الجمعية يعني تبنينا الحملة هذه الجديدة عن المرض لزيادة التوعية. وأنا أظن عندك سؤال آخر عن الجمعية.
نعم، أنواع المرض دكتور.
هو طبعا هو كما قلت النتيجة النهائية هي ارتفاع ضغط الشريان الرئوي، لكن المسببات عديدة. أشهرها وأكثرها عنفا ما نسميه احنا في الطب الغير معروف السبب، ضغط الشريان الرئوي الغير معروف السبب. وانت تسالني عن السبب واقول لك الغير معروف عن السبب.
لان هناك امراض
نعم هذا
او انواع غير معروف.
اي نعم، هو في الواقع الرئيسي.
نعم.
واللي هو شويه عنيف اللي هو الغير معروف السبب. وهناك انواع اخرى طبعا من الاسباب، منها القلبيه، منها امراض الروماتيزم، منها امراض البلهارسيا، منها التجلطات المتكرره على سبيل المثال، وهذه صرنا نشوفها كثير، وهي عادة من الأنواع اللي ممكن علاجها الضغط الشريان الرئوي لأنها تعالج جراحيا، والجراحة هذه بفضل الله متوفرة في المملكة. نعم. فأسبابها كثيرة، إنما النتيجة هي في الأخير هي ارتفاع الضغط في شريان الرئة. المفروض يكون ضغطه واطي عشان القلب لما يتدفق الدم داخل الرئة تستطيع الرئة أن تستوعب كل تدفق الدم من القلب.
جميل. نعم. أبرز المراكز لدينا في المملكة لمعالجة هذا المرض؟
بفضل الله المملكة متقدمة جدا في تشخيص وعلاج المرض. هناك 4 أو 5 مراكز كبيرة. مستشفى الملك فيصل التخصصي على سبيل المثال ربما هو الأكبر والأكمل من ناحية التدخلات الجراحية والعلاجية والتشخيصية، لكن مركز الأمير سلطان أمراض القلب في المستشفى العسكري، المدينة الطبية، منظومة الحرس الوطني عندهم مركزين، في الغربية عندنا تقريبا مركزين أيضا، في الحرس الوطني في وزارة الصحة، وفي تخصصي مدينة جدة. فهناك بفضل الله مراكز في المملكة ويديرها مجموعة من الزملاء متخصصين في هذا المرض وقديرين، والعلاجات بفضل الله.
Assalamu alaikum wa rahmatullahi wa barakatuh. On behalf of my colleagues and staff members, I welcome you to the 13th annual meeting. Thank you all and enjoy. very extensive 3 days. Thank you all and have a safe trip back home.
بفضل الله تم اكتشاف عدة أدوية لعلاج هذا المرض، وبفضل الله أيضا هذه الأدوية متوفرة الآن في المراكز الكبيرة في المملكة مثلا وفي مصر. لكن المهم في الموضوع هو الوصول للتشخيص الدقيق في ضغط الشريان الرئوي، لأن هو المحصلة ضغط الشريان الرئوي ارتفاع ضغط الشريان الرئوي في شرايين الرئة، ولكن له عدة. ورحمة الله وبركاته، أهلا وسهلا بكم في المؤتمر الأول لارتفاع ضغط الشريان الرئوي، وهو ثمرة التعاون بين الجمعية السعودية لأمراض ارتفاع ضغط الشريان الرئوي والجمعية المصرية لأمراض الرئة.
يسعدنا ويشرفنا استضافة جمعية الساف، الجمعية السعودية لدراسة أمراض ارتفاع ضغط الشريان الرئوي في القاهرة يومي 20 و 21 يناير القادمين.
الرحمن الرحيم. الحقيقة أنا في منتهى السعادة إن إحنا في الجمعية المصرية لأمراض الصدر والتضرن يعني يسعدنا كثيرا إن إحنا يكون معنا هذا اللقاء العلمي والمؤتمر الخاص بارتفاع ضغط الشريان الرئوي.
ارتفاع ضغط الدم داخل شرايين الرئة وليس الضغط العام، وبما أن يرتفع ضغط الدم داخل شرايين الرئة والقلب تدفق الدم من الجهة اليمنى من القلب
This is our 15th annual meeting. There has been a significant growth over the last several years in terms of number of participants and number of activities, as well as number of speakers who normally attend our general annual scientific meetings. We have also been doing master classes, workshops, and many other activities both locally and internationally. The SAPH2023, the board meeting was held this morning, and the decision was made to be done 16th to 18th of February next year. So from now, I'm inviting all of you to attend SAPH 2023.
Testing.
Welcome to SAPH 2023. This is our 16th annual meeting for pulmonary hypertension.
Real pleasure to be here after many years, and it's always a real pleasure. Thank you.
Now, the question, therefore, is do the ECHO guidelines, which have only changed marginally from 2015 to 2022.
طبعا الدكاترة بيشوفون مرضى ضغط الشريان الرئوي بأنواع مختلفة.
وكانت في البدايات يعني ما في تحديد لأنه أنتي فاسفولبيت كانوا معتبرينه تخثر دم عادي، واستمريت على الورفرين.
enzymes regulating night, for instance, BMPR2 loss of function,
mediators, genetic drivers, mediators like growth factors.
Have a chance of individualized therapy, measure their risk based on implantable monitors.
Stimulates endothelial angiogenesis and the formations with KLF6 overexpression compared with the control.
System, the organ chip. It's a very small one, so I'm wondering the number.
Study Winston, Wilson in heart failure patients to HX, but when you put them into your organ on a chip and you start exposing
Have a role in the future in that it's in a very in an expert center doing.
And what do you think the inhaled imatinib will?
The new updated guidelines from the definition to the risk stratification to the impact on the treatment.
It was used in different ways by different centers and by a feasible treatment goal for these patients. And the question is that relevant for the patients with
400 patients who started that study being on the ERA PDE5 inhibitor combination background.
By an increase in pressure, and precapillary by an increase in resistance.
Everybody, and that you have patients who are even functional class 2 doing fairly well, and you have patients who are.
We know that zero data for this patient in terms of
is really important, and I see that it really does.
Failure, being a cardiologist and a heart failure specialist.
The cause, initial cause, and it's insisting on the very unique population of elderly males.
6-minute walk test that you're looking at marked or worsening lesions, but vasculopathy is there.
Basically phenotypes. So again, that is super from the data from both Compare and the Aspire looking at.
Utilize according to different treatment strategies.
But these are the metrics that you have potentially
Hello? Hello?
the recommendation level.
In Victoria was very peculiar in the way that that's the overarching mechanism. Then some patients derail.
So the chances of them developing post-capillary is it?
I mean, in the way that we're talking about a disease that it has a lot of high PV.
When Compare data was published, and one of the things.
And people who had people.
One of the key approaches if for such patient you try to optimize their situation.
Diagnosis, then the second part inshallah will be a follow-up for the case. Her CT showed bilateral non-specific ground glass.
Organizers for the fascinating meeting as usual. And
Hello? Okay, thank you. Can you be seated, please, to start program? Well, Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. After having a successful afternoon session for the workshops, it's now officially we open SAPH 2026. So we are all welcome to Jeddah, Saudi Arabia, our 19th annual conference. I would like first to thank the scientific committee led by Dr. Abdullah Al-Khadir for coming up with a very comprehensive program that covers most of the aspects, or at least the important aspects of pulmonary hypertension, and covering the updated research outcome and trending treatment for the pulmonary hypertension in these coming 2 days. I would also like to thank our colleagues who came from outside as international speakers or chairs, as well as our colleagues from within Saudi Arabia or region around us. The program is about 8 sessions that include the workshops, nearly 30 presentations. So it's really a very comprehensive 2 days or 3 days or 2 days and a half, whatever you call it. So I really encourage our colleagues, the attendees, especially the junior staff who are now entering the world of pulmonary hypertension, to really attend these. Most of all the talks are actually presented by a world level expert in pulmonary hypertension. So it's really a good chance for you to learn from these experiences, which is delivered to you at your convenient time while you are actually attending this conference. So in 2 days and a half, we will cover most important aspects of pulmonary hypertension that you really need to have in your practice. I would also like to thank our sponsors who make this event happening. And Hassan warned me last year, I forgot 1 or 2 names. He said, please read them from your mobile. So I'm going to read the sponsors from my mobile, so I won't forget any one of them. So thank you so much, our colleagues, partners from pharmaceuticals, Bayer, AOB Health, MSD, Biologics, Sudair Pharma, Pharma Science, QML, and BD. Thank you so much for your contribution and help and partnering with SAPH for the last 19 years. Few announcements. The dinner will be served after the whole session. It will be tonight here by the pool, just in the same level of this floor. And tomorrow night, all invitees will be, inshallah, taken to a good place outside the hotel. The buses will be ready after the evening session at about 7 o'clock outside the hotel to take us to a good place. It's my pleasure now to introduce our chairman for this session, Professor Majdi Idris, who is, is the ex-founder of SAPH, and he is also a pulmonologist from Military Hospital in Riyadh. And Dr. Abdullah Al-Khadir, who is also an intervention cardiologist, a PH specialist from King Fahd Medical City, also from Riyadh. After this session, we will have our colleagues and partners from different organizations who are visiting us as guests. Will be greeting you and telling them about themselves and what they do in their country. So Majdi and Abdullah, the session is yours.
Assalamu alaikum, everyone, and a great night to you all. Thank you, Abdullah, for the introduction, and would like to welcome you all in SAPH, the 19th version of SAPH, and hopefully this will continue to be the case for years to come. I hope you are really enjoying Jeddah. Jeddah is a very nice place, and take sometimes to visit the different part of the city. Now let's go to the science. It is my great pleasure to co-chair this session with my dear friend Abdullah Al-Khair, and it's my honor to introduce the first speaker, Professor Paul Liu. Professor Paul is a director, Cardiovascular Research Center Cardiology Division, Massachusetts General Hospital. He is an Associate Professor of Medicine, Harvard Medical School from Boston, US, and he will be giving a very interesting talk today about a transforming growth factor beta superfamily and the platelet-derived growth factor pathway. Paul, the floor is yours.
Thanks so much for the introduction, and thanks for the kind invitation to the program chairs, Dr. Aldalan, for this invitation. I have been asked to talk about the history of two important pathways that have been developed for the treatment of pulmonary hypertension that have taken place over the past 2 decades, coincidentally overlapping with the 20 or so history of this meeting. And I'm going to do my best in a short period of time to summarize the work of a lot of people who've contributed. This first part, I'm going to talk about the role of the PDGF signaling pathway, and this is really work that has been led by the group at Gießen. And I should also thank Werner Seeger for sharing some of his slides so that I could talk about this today. But you all know that PDGF is an important signaling pathway, but it has some intricacies. There are multiple homodimeric and heterodimeric ligands that are formed from PDGF A, B, C, and D isoforms. But we think that A and B are probably the most important ligands secreted from the cells that we care about in the pulmonary circulation: fibroblasts, smooth muscle cells, endothelial cells, and even some bone marrow-derived hematopoietic cells. These homodimeric or heterodimeric cell ligands will cross-link on the receptor these dimers of receptors that can also be homodimeric or heterodimeric. And it's important to note that PDGF receptor beta binds to specifically PDGF-BB and PDGF-DD, shown here. And this is of pivotal importance, we think, in pulmonary vascular remodeling. The end result of all the signaling pathways that are recruited downstream, which include important growth and proliferation regulation pathways like PI3 kinase, AKT, RAF, JAK, and PLC gamma, are that we will recruit proliferation, differentiation into contractile phenotypes, migration, and survival. And so just more about this PDGF receptor beta. It is the only PDGF receptor that is expressed on smooth muscle cell and macrophages, and that is why PDGF-BB has particular tropism for this cell type and is a very potent inducer of SMC proliferation, migration, and even contractile phenotype. Fibroblasts have more receptors, but they still respond very nicely to PDGF-BB and exhibit some of the same effects, including extracellular matrix production in response. So many cell types that are encompassed by this pathway with many important effects. So the first illustration of the importance of this pathway was work done from the Gießen group, showing in multiple animal models that the ABL PDGFR receptor inhibitor, imatinib, could treat experimental pulmonary hypertension, shown here from this JCI paper led by Ralph Chamouly. And then right on the tails of that were several patients that were shown to have really impressive acute responses on top of baseline therapy with the addition of imatinib therapy. This was a case series in a letter published in the New England Journal. And this led rapidly to the implementation of a proof of concept phase 2 trial, which was encouraging, and then ultimately to the phase 3 IMPRESS trial in 2013, which showed a very impressive improvement in pulmonary vascular resistance, which was groundbreaking at the time and actually still groundbreaking. There were limitations. There were intracranial hemorrhages, particularly associated with the use of standard anticoagulation therapy in this patient population. That is no longer the current standard of care, so people have wondered if this could be replicated with better results today. There are other inhibitors of PDGF receptor kinases that have varying potency, and this paper from Soni and her colleagues in Gießen showed nicely that the very potent inhibitors, next-generation kinase inhibitors, dasatinib and nilotinib, could show even better rescue in the monocrotaline model and almost complete normalization of the vascular remodeling. And so this is exciting, and also what's shared by these multiple generations of kinase inhibitors is that they do target the core PDGFR alpha and beta, as well as c-KIT, which is closely related, but to varying degrees they target ABL, as well as SRC and ephrin kinases. And these may be not only important for their efficacy in recruiting further anti-inflammatory or anti-proliferative effects in different cell types, but it could also have implications for tolerability, as we discovered with dasatinib, which is such a potent and broad-acting kinase inhibitor. It was found to induce pulmonary hypertension in patients treated with CML at a low but pretty consistent frequency across many cohorts. And there have been speculation as to which targets are to blame for this effect, but it's probably a combination of many toxicities. So can we come up with a multi-kinase inhibitor that combines the good targets and eliminates the bad targets? So seralutinib, many of you are familiar with, combines this activity against c-KIT and PDGFR alpha with CSF1R. And so in addition to the cell types that we talked about, in addition, we would also affect mast cell signaling. And this was also unique among therapies in being designed as an inhaled treatment from the beginning to increase the therapeutic index and reduce the systemic toxicity. And we learned from the phase 2 TORREY trial that there was substantial impact on the primary endpoint, pulmonary vascular resistance, and very good tolerability in the population, most importantly. And so based on this trial, a phase 3 was proposed, and with some slight adjustments. One important adjustment was the requirement that one of these three conditions be present to ensure that a more severe subset of disease was enrolled in this phase 3 trial. Another interesting feature was that even though group 2 through 5 pulmonary hypertension were not included, there was no FVC lower limit specified in the clinical trial. And I think that's important because as you know, many of our patients are not strictly defined by one WSPH group. And there was a sense that this would also be a very good drug for group 3 pulmonary hypertension, in this case PH-ILD. And so this is the ongoing Serenata trial, which has a FVC lower limit of 45%, but otherwise looks for a similar registrational endpoint as 6-minute walk distance at 24 weeks. So while we wait for the results of the PROSERA trial, probably any day now, we can think about what's next. And this is a program that came out of Regeneron looking at PDGF-BB as a target. And so this is a monoclonal antibody that would target all of the homodimers or heterodimers that contain the PDGF monomer. And these would actually address many of the cell types that we've talked about before, but possibly gain some selectivity, and probably would concentrate their effects on the smooth muscle cells over the other lineages. And so this is the trial design for Illuminate, which is a phase 2 study for the anti-PDGF-B antibody. A pretty conventional design with change in PVR at 24 weeks, and this is just beginning. So to summarize the first part, because of the incredible work from our colleagues in Gießen and other people in the field, we now feel that PDGF, and especially PDGF-BB and its receptor, are validated targets in pulmonary hypertension. And these targets are highly enriched in all the cells that we care about in vascular lesions. The IMPRESS trial gave us a sense of the magnitude of effect that we might accomplish, and other kinase inhibitors have varying efficacy and tolerability. And now we have a really second or third generation agent, seralutinib, that's been fine-tuned for its selectivity and its delivery method. But there are further opportunities for greater selectivity, and we'll see how these shape up in the clinic over time. Okay. So I'm going to transition now to the second part of the talk, which is focused on BMP activin targeted therapies for pulmonary hypertension. This work started with the discovery of the first BMPR2 mutations in pulmonary hypertension over 25 years ago, but led through a lot of work in clinical genetics to the identification of at least 14 or 15 other loci that have been validated for heritable pulmonary hypertension. And it's always struck us from the beginning how closely the loss of function loci align with one side of this pathway. All the loss of function mutations are on the BMP signaling side of the pathway. And even with that first Nature Genetics paper by Kirk Lane and his colleagues, there was a hint that maybe this disorder was due to an imbalance of lack of signaling on this side of the pathway and maladaptive or excessive signaling in this pathway. So we now have 20 years of pharmacology to test whether or not that actually holds up. And it's a simple idea. Early on, people used TGF-beta inhibitors, and we're going to hear some more advanced TGF-beta inhibitors later on in this program. But our group used a ligand trap that just bound to 2 isoforms of TGF-beta and showed very good clinical efficacy. And this led us quickly to partner with a pharmaceutical company that had developed other ligand traps that could bind to other ligands of this pathway that were focused on this TGF-SMAD2/3 side of the pathway. And this was ActR2A, which we now know as sotatercept now, and this was originally developed for anemia and very well de-risked with over 400 subjects across 8 trials for anemia and in healthy subjects. And the story of why it didn't go to the clinic for anemia is sort of more about drug development strategy. There was a newer agent that had a longer patent half-life and was maybe more optimized. But this is the wild-type human receptor expresses an extracellular domain. And so with Acceleron, we asked a very simple question, which is, if you block these other ligands on the pathway, does it give you any added benefit over just blocking these ligands, which we already knew contributed? And what we discovered was pretty remarkable from the very first experiment, which was that in this angiobliterative model using Sugen hypoxia in rats, where the remodeling can be quite impressive, and the pressures are not high here, but if allowed to progress, can proceed over 100, we got essentially normalization of the pressures in the RV hypertrophy and regression of much of, or prophylaxis of much of the remodeling. And we tested this in multiple other models, and some themes that emerged were that the effects were anti-proliferative in the vascular wall and maybe restored apoptosis sensitivity to some of the vascular cells. There were evidence of inflammatory effects with the expression of adhesion molecules that could be, and other chemoattractant molecules in the vascular wall. And there was also evidence that this pathway regulated smooth muscle cell phenotype. In comparison to TGF-beta, many of the same genes were upregulated by activins A, B, and GDF811, but to very different proportions. So there is a fibrotic phenotype of activin ligands that's been well described in other disease literatures, like in the kidney fibrosis literature. But what we felt we were seeing were the effects of this profibrotic effect of activin ligands in the vasculature. So this is a pretty broad paintbrush because you're inhibiting about 17 ligands of this pathway that has 33 ligands. And does this really, is this the most selective strategy that can be used? So we tested this idea a number of ways. We used different cocktails of antibodies targeting anti-activin A and B, or targeting GDF8 and 11 to see if we could reconstitute the activity of sotatercept by additively blocking more and more ligands. And what we found was that by blocking 2 ligands at a time, the effects were pretty modest, but if we blocked 4 ligands at a time, they would start to approach the effects of sotatercept. This is a 4-week prophylaxis model, and if we got 50% close to the baseline in the cocktail, we got close to 95% with sotatercept. So clearly, there's probably something beyond these 4 activin and GDF ligands that are driving the efficacy of sotatercept. So I'm going to talk about what we think those other ligands are. But just to summarize, sotatercept acts on many cell lineages with antifibrotic, anti-inflammatory, anti-myogenic effects. And we think that activin and GDF probably only explain part, maybe 50% of what sotatercept does. Okay. So the last part of my talk is going to challenge this paradigm a little bit about TGF-beta and SMAD2/3 as being solely the drivers responsible for pulmonary vascular disease versus the concept that SMAD159 is purely protective. And there is, I'll show you some of the data on both sides. So this is the work from Nick Morell's group that we also contributed to, showing that a recombinant BMP9 molecule administered systemically in 6 different models of pulmonary hypertension could really nicely normalize pulmonary vascular phenotypes based on RVSP, RVH, as well as normalizing the angiobliterative activity in this model run to 11 weeks. You could see that it actually could be quantified that more vessels were recanalized apparently after treatment late in this model. And there are other clinical observations that supported the idea of a protective role of BMP9. This is work with our colleagues in the liver transplant groups at Tufts and Mass General, showing that BMP9 was a very strong biomarker of portal pulmonary hypertension and can actually predict outcomes, transplant-free survival, in this case being defined as liver or lung transplant. And there's obviously a genetic set of evidence here. Around the same time that we started these studies, it was found that certain populations were enriched for BMP9 mutations. And now looking at many international cohorts, it appears to be about 1% of our total PAH population that has loss of function mutations in BMP9. And these are bona fide BMP9 mutations that reduce the expression or reduce the activity of BMP9. But work from other groups started to challenge the idea that BMP9 could only do good and only be protective. This is work from Mark Ormiston's group in Queens, showing that BMPR2 wild-type cells, endothelial cells, had a nice anti-proliferative effect with BMP9, while heterozygous cells lost that anti-proliferative effect, and mutant cells that were homozygous for loss of BMPR2 suddenly gained a pro-proliferative effect of BMP9. So made us wonder if maybe in the context of disease, especially in the case of inherited mutations of BMP9, might lose its protective function or take a pathogenic role. And the group from France, led by Christophe Ginebert, Sabine Bailey, Marc Humbert, then found that BMP9 knockout mice were actually protected from pulmonary hypertension, that delivery of an anti-BMP9 neutralizing antibody was protective in wild-type mice. And then in rats that were given monocrotaline or Sugen, the administration of a combined BMP9/10 ligand trap was protective against pulmonary hypertension and remodeling. And so this is the complete inverse of what we saw with those early experiments. So we sought to test whether this was actually the case. And we wondered if this might be having to do with the timing of the delivery, since these were given to already sick mice or already sick rats. And I'll summarize just by saying it doesn't matter when you give an antagonist to BMP9. It is protective before the vascular injury, it is protective during the vascular injury, and is protective after the development of pulmonary hypertension. And in fact, so this is the slide showing that. If you give it before Sugen hypoxia, it's protective, and after Sugen hypoxia, it's protective. And then we think of Sugen as a VEGF inhibitor, as an anti-angiogenic insult, and we think of neutralizing BMP9 as potentially a similar kind of exposure. In fact, this drug, ALK1FC, was originally explored as an anti-angiogenic therapy for cancer. And so we wondered, could we replicate the effects of Sugen by combining this BMP910 trap with hypoxia? But it didn't happen. It did not replicate the effects of Sugen hypoxia or even exacerbate hypoxia. It actually normalized the hypoxic-induced pulmonary hypertension. So any number of ways that we were blocking BMP9 and 10, we were getting improvements in the experimental pH phenotypes. And we wanted to know, how does this compare to sotatercept? So we actually ran a head-to-head study of ALK1FC, of a commercial anti-BMP9 antibody, and sotatercept. And a couple surprises here. The efficacy was very similar, whether we looked at vascular remodeling, right ventricular hypertrophy. But if we looked after 3 weeks of treatment, that was maybe too late. We decided to look early at week 4 with only 1 week of treatment. And we were surprised that even with only 2 treatments, 1 week after removal from hypoxia, we were already getting marked improvements in right ventricular hypertrophy, suggesting that the effects of these ligand traps and ligand blockers may not all be due to remodeling, that there may be some acute effects that could be seen as quickly as in a number of days. We analyzed that 1 week data because we felt that that would be enriched for mechanistic drivers of this phenotype and found a couple of interesting things. Sotatercept, which is Actor 2AFC, and the anti-BMP9 antibody certainly reduced the expression of SMAD2/3 targeted genes, but in every lineage that we looked at, this is a single nuke RNA-seq experiment, whether it's endothelial, fibroblast, or smooth muscle cells, both SMAD2/3 were suppressed, as well as SMAD159. So all these treatments that are supposed to restore or affect the balance of signaling, they actually inhibit both sides of the pathway. And we went a little bit further and looked at the genes that were reprogrammed in the endothelial cells. And this is a graph showing the genes and the magnitude of change with sotatercept versus anti-BMP9. And I want to show you that the correlation is 0.83 with a significance of 10 to the minus 43. There is incredibly high overlap with the genes that are upregulated and downregulated with just inhibiting one ligand, BMP9, versus the 17 ligands inhibited by Actor 2AFC. And these are some of the highest scoring candidates, including many molecules that you're familiar with, like connective tissue growth factor, CCN2, CXCL12, fractalkine, FRZLB. These are all the things that we've been thinking of for the past 2 decades of this. But what is interesting is we can use some modern tools for looking at what's happening to our cells. These are not proof, but they're suggestive. And what they find is by trajectory analysis, there is a shift from GCAP cells to arterial ECs, probably coinciding with the muscularization program seen in our disease. And that shift is reversed both by sotatercept and by anti-BMP9. So where we're restoring the GCAP and reducing the arterial ECs actually to a very similar degree. And in actuality, the serpent high fibroblast population that was described by Sony's group in the RV actually seems to be impacted in the lungs by the treatment with some of these ligands. So, some of these motifs extend between the RV myocardium and the lungs. So I'll speed through this just to tell you that there's more evidence for blurring the distinction between SMAD1/5 and SMAD2/3. When we look at human lungs that have been compared to PAH versus healthy lungs by microarray or by single-cell RNA-seq, and we look at BMP9 regulated lungs, the BMP9 regulated genes, these are genes that are upregulated or downregulated by treatment with anti-BMP9 in vivo at that 1 week time point versus just the disease in general. There are a short list of candidates that I think many of you have already heard about in other contexts in pulmonary hypertension. I want to tell you a little bit more about CXCL12. In fact, CXCL12 is enriched in the endothelial cells of pulmonary hypertension, and it is particularly enriched in that arterial EC population that we think is marked by an increase in disease. And CXCL12 is very potently regulated by BMP9 in endothelial cells. And we know that CXCL12 by itself can induce pulmonary artery smooth muscle cell contractile phenotypes. So the question is, can paracrine endothelial smooth muscle signaling be an explanation of some of the effects that we're seeing? And so if you expose BMP9 to just smooth muscle cells, you won't see much in the way of phenotypic changes. But if you expose smooth muscle cells that are co-cultured with endothelial cells, you'll see large increases in contractile genes like calponin. And this increase in calponin can be blocked by neutralizing CXCL12 to some degree. It can be blocked by inhibiting its receptor, CXCR4, to some degree. And if you're using serum, which contains BMP9 to induce this contractile phenotype, it can be blocked by inhibiting the BMP9 that is in serum. So it's not the only explanation, but it's probably a major contributor. So what was really curious is that some genes downstream of BMP9 are regulated by SMAD1/5, and some genes are regulated by SMAD2/3. It turns out that CXCL12 depends on SMADs 1 and 5 and doesn't actually require SMADs 2 or 3. So this whole good and bad sides of the pathway doesn't even apply for one highly pathogenic molecule. Let's look at another molecule. This is endothelin-1, which we have been targeting in pulmonary hypertension productively for over 2.5 decades. So I don't need to tell you about that. And there's this nice published work from Christophe Ginebert's group that showed that BMP9 has vasoconstrictor activities that can be blocked by bosentan. That part of the contractile effect of BMP9 in this chick coriolantic membrane model is actually due to endothelin-1. When we look at the gene regulation for endothelin-1, it is the opposite of CXCL12. It depends completely on SMADs 2 and 3, which would have been our original prediction. And we find that with all those genes that we listed that are downstream of BMP9, half of them fall on this side and half of them fall on this side. And we're trying to understand why this actually takes place. We've done some promoter bashing, and it turns out that some genes like endothelin have both SMAD2/3 responsive elements and SMAD1/5 responsive elements, where the SMAD2/3 elements are enough for you to activate signaling by TGF-beta, but the NF1 SMAD1/5 binding element is what confers sensitivity to BMP9. So more to come on that, but basically this is our model of what's happening. We think that BMP9 probably overlaps with some of the activity of sotatercept, and that the downstream targets of both of these pathways impinge on SMAD1/5 and SMAD2/3, and some of the targets fall on either side. I know it's complicated, but this is where we're being led. And so this idea that we originally had that neatly we could just confine all the pathogenic effects to this one side of the pathway seems to not be the case, that there's some bleed over into the BMP side, and especially with this one ligand, BMP9, which can activate both pathways. We don't know which side of the pathway is more important. We suspect both are important. There is a phase 1 trial now that has now extended to a phase 2 early signs of efficacy trial being run by Pfizer, which is testing this concept using a high affinity anti-BMP9 antibody. And so we look forward to hearing about that in the next year. So just to summarize this last part, there's definitely a paradox of function in BMP9. The genetics is at odds with what we see experimentally. BMP9 is a very pleiotropic molecule. It probably does things in different contexts, and it secretes or targets so many different secreted products that you could imagine it could be an important coordinator of cell transitions in endothelium. And then this prompts us to ask, did we misname the sotatercept class of drugs? Should they really be called activin signaling inhibitors, or should they be called activin and BMP signaling inhibitors? And finally, we look forward to hearing the results of this trial to see if just antagonism of BMP9 alone might be tolerable for pulmonary hypertension. And with that, I'll thank our many collaborators. Thank you for your attention. I'm happy to take questions at the end of the session.
Thank you very much. That was amazing. Next is a topic that I look for every year in this conference, which is a year in review. This year is presented by Dr. Hassam Sakijha, who's a consultant pulmonologist at King Fahd Medical City, and I'm pretty sure he will take us through a nice dive in this topic. Dr. Hassam.
السلام عليكم. Good evening, everyone. Thank you, Abdullah, for the introduction. And thanks for the scientific program that made my life a little bit difficult because I tried to avoid the content. And most of what I'm going to talk about, I think the authors of the papers are from the audience. And that would be a great chance to interact with them and, just check with them about the results of their studies. The first one was of interest to us, although the design and the outcome or the results were not of a great methodology, but this is the best thing we have about the global burden of the disease. This has been going on since the 80s, and pH was mentioned as other factors under cardiovascular diseases that can contribute to the mortality and the burden on just the human beings. So this now is a set of analysis of the data that was already collected and published for PAH alone. The data came from 200 plus countries, and it's whatever available. The accuracy, the scientific rigor of the data is always questionable, but this is an epidemiological study that tells us where we are standing. The numbers you see here is per 100,000 population, and we're talking about in general. So if you see the prevalence, 2021 had a prevalence of 2.28 cases per 100,000 people, not necessarily by right heart cath as what we do in the clinic, but this is what is being reported as PH. Of these, the mortality attributed to PAH was only 0.27, and of course there is some limit of inaccuracy there. So being still a rare disease, this is what we have, and the importance of this, I think it will in the future draw some resources. Looking at a standardization of the data, because this is a global study and looks at multiple areas. If you see the, based on females and males, it's more obviously more common in females as we see in the clinic. Certain areas are more common than others, probably reporting related, but this is what is the data. When you start looking at the age, it is more prevalent in really older age. We're talking about the above 70, 75. This is the most prevalent group that they are attributing it to it. And when you look into the mortality, same thing. They look at it by sex. The Middle East, if you see in the middle of the slide here, the Middle East has somewhat higher mortality attributed, and that's what is being reported. The cause of this person had is because of pulmonary hypertension, and again, the age group that is in the mortality was among the older population. What else this study or this type of epidemiological study look at is the disability adjusted life years attributable to the disease, and they look into two metrics to come up with this number: year lived with the disease, if the disease is chronic, and how long does the patient will live with the disability, and years of life lost because of the disease. Here, this reflection of the rarity of the disease, the numbers are somewhat small. It's about 8, if you look into the total, 8.03 for the year lost. And there is no big difference between the disability adjusted rate and the year lost, simply because people don't live that long to really just be counted as living with disability. This is important if you compare it with other diseases, and you can see cancers. We are similar to the cancer in this sense, where there is not much difference between the adjusted disability and the year lost from the disease. Trend is more important. This has been going on, like we said, since the 90s, and you see the incidence is on the rise. The number of deaths due to the disease is plateauing somewhat in the last 10, 12 years or so. And if you start looking into the number of the disability-adjusted years, it's kind of starting to come down. The upper numbers are per 10,000. It's a different paper with different, same data, but looking at it in a different sense. And the lower bottom lines, it shows that the age-adjusted death rate is decreasing. So this is probably the effort of our interventions, early diagnosis and interventions, and as well as the disability-adjusted rates. So things are going probably in the right direction. This is needed for the support from government, the funding agencies, and at least to really know where we are. From this point on, this PAH will be reported on its own rather than being part of other diseases. The second paper I wanted to talk about is an intriguing one, although the data is not out there, but we saw this paper that describes the development of a novel pulmonary endovascular device to treat patients with pulmonary hypertension. The idea here is to address the right ventricle itself. We all talk about the pulmonary vasculature, the PVR and whatnot, but this is unique. First, it's a device, and it addresses the pathobiology of the disease itself in terms of hemodynamics. And I liked it because it's really nice. There is a paper ongoing or a trial ongoing in the US that is funded and supported as a concept. This is an early phase intervention, let's say, in humans. A lot of studies in the animals that shows that this can be, as a concept, durable. And I will mention to you how it works. Complicated, but we know in pulmonary hypertension there will be a problem with coupling between the ventricular function and the distensibility of the pulmonary artery. As the disease progresses, things will get out of control and we will have decoupled ventricle. Consequently, the patient will have symptoms and probably they usually die. So this ratio is very important, and we call it coupling between the ventricle and the pulmonary artery. The way it works normally, the right ventricle will pump the blood will go into the circulation. Normal conditions, everything is great. There is not much resistance. Most of the blood will go and takes its time to reach into the pulmonary circulation. When we start having a problem, a lot of this blood will be pushed within short period of time with a very high systolic pressure in the pulmonary circulation. And then during diastole, there is not going to be continuing to feed into the pulmonary circulation because the artery will become stiff and we will lose this distensibility part of the artery, which works as a reservoir where it will maintain perfusion during diastole. This is what normally happens. In the disease, as it progresses, we will lose this, and there will be a reflective wave from the pulmonary artery back into the ventricle, adding up to the load the right ventricle has to work against. And this load is actually an essential component into the disease and the consequences of the disease. So the idea, I'm going to skip through this. These are two ventricles that one is remodeled and one is able to handle the load with a good contractility. So the difference is there until the patient will reach into a point where there will be too much dilatation and unfortunately the patient will succumb to their disease. This decoupling occurs because of the progression of the disease, and we hope that we can intervene and prevent this from happening when we address the PVR part of it. What does the device do? It will be minimal invasive surgery. It will be introduced into the pulmonary circulation. It will be anchored there, and there will be a balloon that's filled with air, and as a reservoir that will be implanted under the skin in the abdomen. During systole, the pressure inside the pulmonary artery will squeeze the air from the balloon. It will go to the reservoir, and the blood will be propelled into the pulmonary circulation. As the diastole occur, now the balloon will start filling again because the pressure is coming down. This will protect the right ventricle from the back pressure from the pulsatile group of the load component, and it will maintain perfusion during the diastole. I think this is very intriguing. Still, we are in very early phases, but at least we are addressing the right ventricle. Maybe it will have a good room to deal with patients who come with decompensated right ventricular failure in the ICU and the CCU, and probably for a longer term purposes. The next one is coming from French group. We have them with us today. The guidelines 22 were stressing the importance of comorbidities. People did not like it, and we did not really buy much into it. If you have PH, you have PH. The new proposed guidelines or data coming from is just to ignore this comorbid group, and they looked into the data from the French registry. Incident patients, they had a very large registry, and they managed to actually get about 1,784 cases in the study. They distributed them. This is from 2010, I think. That's why you will see a lot of people, they are started on monotherapy. They distributed them amongst with comorbidities and no comorbidities. They have 1,088 patients with some comorbidities: hypertension, diabetes, obesity, obesity and coronary artery disease, and they looked into their data after their distribution into whether they are on monotherapy, the majority of which were on monotherapy, 60%, 37% were on double combination therapy, and only 3% on triple therapy, similar to the current practice that was, longer practice at the time. And they start looking into the outcomes. And you won't be surprised that every single parameter that you look at, people who were started on double combination therapy, being, the ERAs and PDE5 inhibitors, they did better, statistically significant than other components. And this is just reflective of the 6-minute walk test, the change in the PVR, and even in the risk strata of the patients. Of course, as the time goes by, more people who were on the monotherapy, they will require addition of a second and probably third agent, but did not reflect much on the mortality. At the end of the day, this approach helped the exercise, helped the hemodynamics. The mortality was not much different. People are always scared from the increase in the wedge pressure as you vasodilate the pulmonary circulation. So they specifically looked into the numbers of the people who had increased wedge pressure. Good news that none of the people who had mortality, whether it is because of the wedge pressure elevation or no elevation in the wedge pressure, attributable to mortality. So there is no difference. And the numbers out of the people with no comorbidities, 3% of the people will have increase in the wedge pressure. 8% of the other group, the ones with comorbidity, will have increase in the wedge pressure, 10% from the combination therapy, and 7% from the monotherapy. So the numbers are really not very much justifiable, and probably with a better monitoring of the patient, selection of the patient, things will probably better. So the conclusion is that when you have a very good selected group of patients, even if they are older with comorbidities, approaching them as what we approach our usual patients, being sicker, maybe a bad disease, to give them double combination therapy, it does have reflection on the exercise capacity, hemodynamics, risk of mortality, but it did not show much of the mortality outcome at the end of the day. So this is, I think that's very relevant. It will educate further researchers. Some of the data has already been looked at from clinical trials, kind of showing the same thing, whether that if you select the proper patient, meaning that they have PAH with comorbidities, I think we're fine. The issue is that sometimes we don't select the right patient and we end up misclassifying the patient having a heart failure or type 2, and then we vasodilate them and they end up having a trouble. This was an very interesting late-breaking abstract presented at ERS this year that is talking about treprostinil palmitil, which is a new drug. It's a broad drug. It's not the same as the treprostinil that we all are familiar with, and we are using it. And they managed to do it in a very interesting drug delivery. I think that's where the innovation is, to the point that it is a powder and it is delivered only once a day to the circulation. And they did a phase 2 trial to show the results. I'll show you the idea behind it. They get a treprostinil and they attach it to some lipid component, and they do put it in a nanoparticle. The middle of the slide, you'll see the nanoparticle, and this will protect the molecule from being degraded from the lung. Once it's released into the lung, there will be some staged release, and the lipoprotein lipase in the lung will cut the protein or the lipid component, and the drug will be readily available. So this is where the technology is. This is where the science and innovation is. And they did want to, come up with a phase 2 study that was randomized, double-blinded, looked into patients with PAH, 2-to-1 randomization, small number of patients, fitting the nature of the study, 102 adults. And they chose increasing incremental doses from 80 all the way to 640. And the primary endpoint was change in the PVR. 35% placebo-adjusted reduction in the PVR, highly statistically significant. 35.5 meter improvement in the walk distance when they looked into the two groups. 60% reduction in the BNP after looking into the study. So this is very impressive. The technology, the availability, one inhalation powder, the patient just takes it once a day. And if it will work in phase 3 trials, that will be probably a very good tool. And always our prostacyclin pathway is important. We always put a lot of weight for it, but now it's probably being delivered in a very simple and easier way on the patient. So hopefully we're looking forward to the phase 3 trials that already started. They are looking at it for PAH and for PH with interstitial lung disease. And I think this we'll be waiting to see the results in the future. Some of the talk about seralutinib was mentioned earlier, so I'm not going to go through the basic science behind it. We presented the Touré study that was phase 2 study looking into the use of the molecule in our SAPH 2 years ago, and it showed that there is an improvement in the PVR, there is improvement in the 6-minute walk test, and as mentioned earlier that we wanted to see patients who are somewhat sicker, the walk test, the PNB showed improvement, and the hemodynamics were not so strong, but there is a statistical significant improvement in the mean PA pressure. Now, the adverse events were tolerable, not much other than cough and some simple side effects. They wanted to look as well into the extension of this study later on for the patients who have continued to use the therapy. And this is the result that was published a couple of months ago, showing that people who were continuing on seralutinib continue to show improvement in their PVR, and the ones who were placebo rolled over, they start showing improvement in the PVR. Of course, the 6-minute walk test continued to improve in the continued patients to 30 meters plus, and the ones who were rolled over start improving to 12 liters. The BNB has improved in the rollover group, start to come down a little bit. The effect is kind of not completely lost. Still, it is statistically significant improvement relative to the baseline, but this is the data they published. The PVR changes from the baseline is starting to catch up, and this is a consistent improvement so far, at least over 72 weeks. Safety was okay in general. We learned that there is maybe a slight elevation in the liver enzymes that was confirmed and looked at into the phase 3 trial that is already conducted and in the plan for publication hopefully soon. We just logged the data. Our centers, King Faisal and King Fahd Medical City, were part of this study. I just signed the papers. The data is logged, and it's just being in the process of cleaning. So probably a few weeks we will have results from this study, unless we hear something sooner if there is an outbreak, and it will be through a company, just announcement. So I think that's just an update to where we are in that regard. Since we are talking about remodeling, the genetics of PH is intriguing, it's interesting, it's important. A lot of push, you will see a lot of papers telling you, do test your patients. The idea is that you just wanted to see, this is opening the eye to learn more about the disease. A meta-analysis was looked at. I was not very impressed with the results, but it shows what we already know. The meta-analysis was good. They identified 17 studies. Finally, they looked at, and there is worse mean PA pressure in patients who have the genetic variant. PVR is worse. If you look into cardiac output and cardiac index are worse. No much changes in the right atrial pressure and the wedge pressure, but the size of the changes is not that impressive. Every time I see a genetically, caused patient with PH, they are very sick. Definitely their mean pressure is high. They tend to die sooner, and they are very aggressive disease. So this is just the only catch that I had on the study, that it did not capture what we see clinically. And I'm sure most of you do have patients like this, but again, data is data. This is what is being published, and we continue to encourage the check of the genetics because this is the way to go. Genetics has helped us to understand the pathway that was presented earlier, and the sotatercept idea came from understanding this genetic work. This meeting is heavily covering the sotatercept, but we congratulate them on the Zenith trial that was stopped early, because this is not a common happening that we see, a clinical trial that is stopped because of efficacy. So that happened with Zenith, and I congratulate them on their ethical component, stopping another clinical trial simply because when you lose the equipoise, you should not continue doing research, and this will defeat the purpose of really looking, and the drug probably can help patients. And they published that Hyperion trial that was prematurely terminated, and I'm sure you will know all the data later on. I just wanted to hint towards it since we're talking about this. Back to the basic arena, I know you had probably an overdose of basic science in the previous talk, but this is something that we are being asked to participate in. We are approached to participate in this clinical trial. I'll tell you the story behind it. And again, it's a basic science looking into the same pathway of the BMBR2 and now addressing something called SMERF1. And this is a protein that will modify the BMB molecule and sometimes the SMAD. And this is just somehow it was noticed to be exaggerated response or expression in the patients with pulmonary hypertension. It will ubiquitinate the protein, making it ready for degradation. And when you have too much of this SMRF, that means that there will be a reduced BMPR signaling, and probably it can contribute to the disease if we believe in the general notion of the balance between activin and the protective effect of the BMPR2. It was looked at into human studies, and the cell cultures showed that in PAH, there is increased expression of this SMRF1 in the smooth muscles of the pulmonary artery, as well as if you look into the pathology of it or the histopathology, you will see more expression in the pulmonary circulation. This is a very tricky molecule because it is unique. It's, the area of activity of the protein is somewhat hidden. It was not easy to identify. And AI has played a major role in understanding how does this protein work and help in identifying inhibitors for it. But they identified that the protein will be taking a thioester from some donor, and it will carry it and it will take it to the protein, which is the BMPR receptor and the SMAD, the good SMADs, and it will lead to, degradation of the protein. This area was not easy to identify, but the AI has helped identifying the area, the hinge, and understanding the mechanism. And this is, again, one thing that we have probably an advantage today, that we are able to look into the informatics and looking into very advanced technologies in the AI that can support the purpose of science, and it will make our life a little bit easier, maybe faster, and identification of molecules at a very complicated rate and input, so that it probably was not very feasible in the real life. You might hear a little bit about the AI. We have people interested in this publication, not only in the diagnostics and risk stratification, but also in determining, some of the personalized medicine, if you wish, and having molecules that will be identified. The molecule we're talking about is a molecule that is blocker of this SMRF. It's called LTP001, and it just shows that this is something that probably works. We proved that this is important in pulmonary hypertension by animal models or by the cell cultures. And in animal models, it was looked into two animal models for the PH, the macrocrotyline and the Sugen, and both of which have showed improvement in masculinization, and this happened after the full development of the disease, as well as decrease and regression of the modeling of the blood vessel that takes place. So in the animal model, this is positive. It shows some benefit, and probably the company has pursued this. They're looking at for two indications, the PH and IPF. The IPF program has been shut down, and this same study, same molecule, they terminated the study in pulmonary hypertension for reasons I'll show you now. It did not show any benefit. I was surprised that they are pushing for the, more work on it, although it was completely negative. They used only 6 milligrams of the molecule in this study. And now the study that we're looking at, they will go to the dose all the way to above 1,000 milligrams. So it looks like they were completely underdosing the drug. The concept is very intriguing, scientifically very plausible, so that's why they are wanting to pursue this. So I think there might be a potential here, talking about the same kind of pathway in a different setup, and we will see what will happen in the future. Probably we are going to be participating in the study. I think I just heard that we got approval from the IRB. It is orally administered as well. This is another unique feature about this, that this is an oral therapy. We'll talk about the CPET study. We have Luke with us here, and we congratulate them on their publication. The only caveat on this is who has CPETs in their institutions? It's just that we all are pulmonologists, or most of us are pulmonologists. We use CPET sometimes. It's helpful, but again, it's not very commonly available, and lots of people, they don't understand how it works. Just give me the report, and I just want to know what to do to my patients. Give me a number. They have very good program. They have patients all the way back from the 2010 all the way to 2022, I think, and they have good number of patients they wanted to explore. let's look into them. And everybody is looking at their data, mine as well. Let's have our data looked at and see what would the CPET data shows. CPET comes or shows in the current guidelines in the form of what do you expect to happen to the patients with PH, and this is very well known. And it went into the prognostication or risk stratification of PH, but nobody does it. If people will use 6-minute walk, and because these are simple tests. CPET is a research modality. I remember we were reading the CPET for Sturridge and Valerie McLaughlin back in the days. So it was more of a research study rather than clinical. But again, there are some clinical value if you have access, and it's a great value that can be utilized if you know how to use it and you have the access to it. And it says that you low risk, you wanted the peak VO2 to be above 15 and the VEV-CO2 to be less than 36, the slope, and if it's high, it will be below 11 and more than 44. Now, what they did, they looked into their data. They included all the patients who have incident disease, and they have 2 CPET studies that were done within the first year after initiating therapy. And sure enough, they correlated it with hemodynamics because hemodynamics are strong. And this is something that you cannot, it's very solid, hardcore data that you can really relate to. And the correlation was great. The correlation coefficient among the 3 major important parameters with the CPET correlates well with the hemodynamics. And they did into multiple logistic regression, and they identified the 3 components that are statistically significant, which is the peak VO2, VO max, the VEV-CO2, and the peak oxygen pulse as important parameters to look at. That's not it. They looked into the stratifying these patients into a 3 strata in the beginning. But what is more important is the 4 strata. So they came up with a risk score similar to what the French did. If you have this number of parameters with the low risk, intermediate risk, and high risk, and they came up with 4 strata distribution of the CPET results. And surprise, look into the distribution of the data. Only CPET alone has very discriminatory when it comes down to risk stratification, and it was actually better than other risk scores that were already being in use. They did further look into it. Why, if we replace the 6-minute walk with the CPET, which is, you are replacing something that is surrogate, maybe moderate correlation with the real gold standard for exercise capacity. And sure enough, it did have better correlation with the outcomes if you really take it into account when you do your stratification of your patient using CPET instead of the 6-minute walk test. Like I said, this is a great news. This is wonderful. And actually, the area under the curve was 0.82, which is better than the currently used risk stratification model 0.73, the C-score for it. So is it going to be applied? I'm not sure if the committee on the guidelines will say, okay, this is a must, you will stratify your patient using CPET, but again, it is some piece of data that is worth mentioning, and we should have mentioned it as well. I will finish with the SAPH. We don't want to forget about SAPH. We have Dr. Matsubara with us in this meeting, so he can shed more light on what I'm going to present. They have a very interesting, of course, Japanese has taught us how to deal with this, SAPH and the balloon studies, and they looked into their data and they published their results in a registry format. Probably I did not have the full numbers. They have 1,202 patients, and they did 5,207 procedures over 44 hospitals. Probably out of these 44, only 2 or 3 were very high volume hospitals, but that did not make a huge difference. Look into their numbers. They were really pushing it. 37.3% of the patients had mean PA pressure less than 20. 71% of their patients had mean pressures less than 25. And 55.6 have PVR, percent reduction, have more than 50% reduction in their PVR. And this is very clearly shown by the data. You improve your PVR, you improve your mean pulmonary artery pressure, and your cardiac index improves as well. When you looked into the survival, they have very impressive 3-year survival of 94.7%. And when they compared the high volume and low volume, there is no much difference in the survival. One additional small point that of interest, we always talk about, do you give your patient the DOACs or you will give them the warfarin, vitamin K inhibitors, and it looks like it does not make a huge difference in the overall survival, at least based on this large cohort of patients. Another impressive point, the side effects or the complication rates were in general small. The worst is 5.6% in hemoptysis, but the other serious complications are non-existing. And when they compared the low volume and high volume centers, the outcome is probably comparable in terms of PVR and cardiac index and PA pressure, but maybe the high volume, they do a little better in terms of safety. So again, it's a very doable procedure. We encourage people. We are proud of our FAIZ experience at Faisal. They are really building the program, and we are hoping that this will be great, because the next article came from the Japanese group, and they looked into their historical data, and it's very, very impressive. In the early phase, when between the 80s all the way to 2000 to 2010, and 2010 till now, look into the differences. Almost all their patients are undergoing a balloon. Very few of them they have endarterectomy, and everybody is getting treated, which is completely opposite to the previous era. And the outcomes are very impressive. When you are talking about survival rates in the above 93, 94%, this is very, very impressive, and we congratulate them on their work. And I think this is something that we can always learn from and try to adopt into our practices. That's it for today. I really thank you and thank the committee for allowing me to be with you tonight. It's always a pleasure and honor, and welcome you to Jeddah, and from the bottom of my heart, not because of Valentine, but I want you to enjoy the meeting, and I am very pleased to see you all. Thank you.
So good. Thank you so much, Hassan. Please. Now the floor is open for questions. So there is microphone. So if anyone would like to ask questions, please do that. Okay. So maybe I can start. Dr. Paul, now we have learned that definitely combination therapy is the way to go in pulmonary hypertension. Do you believe that very soon we're going to see a study looking for example, drugs such as sotatercept and seralutinib in the same patient, targeting two different pathways in the same patient?
I think that's the next logical step, right? We have some preclinical data, I think, from Gossamer showing that in preclinical models, the effect can be additive. And we know that as we are trying to run trials as sotatercept gets adopted, that we have to include patients that are already on a sotatercept background therapy. So our trials will have to be powered to detect that additive effect. I think that's the expectation.
Any question more? Okay. So, Hussam, thank you so much for having that kind of good revision. I wasn't very clear with this device that's used now in the management of pulmonary hypertension. So now the device will be inserted in the pulmonary artery?
Yeah, it's a mini surgery that will insert the device into the pulmonary artery. It will be anchored in the artery, and the balloon will be attached to it. The whole device will be attached to a reservoir for the air.
Right.
So it's imagine yourself, you have this balloon inside the pulmonary artery, similar to what we do the right heart cath, and the balloon will self-inflate and deflate by virtue of the pressure in the pulmonary artery. So as the systole takes place, the air inside this device will go to the reservoir, so allowing the blood to very nicely, forward, without having a very rapid increase in the pressure, to flow through the systole to the pulmonary circulation. As the pressure during the diastole start coming down and easing up on the pulmonary artery, the air will go back into the balloon, and this will protect the right ventricle from the pulsatile component of the PVR, the load on the right ventricle. So this is the idea, that you are giving the ventricle a chance to perfuse during diastole. We know the right ventricle is different than the left ventricle in that sense. The perfusion is mainly during diastole, and you do need that perfusion component in the diastole, so it will protect the right ventricle from ischemia and from consequences related to arrhythmias and whatnot. So this is the idea. It was beneficial and it showed that it works in animal models. They have few patients already enrolled. A small study, just a proof of concept in humans in this stage. So we're waiting to see where this will lead to. But again, I think cardiologists, cardiovascular surgeons will be again aware of this because they do now a lot of implants for patients similar to the ECMO, sometimes Ampella, and to support the heart. So again, this is something unique, interesting, intriguing, and we'll see where it will take us.
Luke, please.
So I'm not going to talk about CPET, but thanks for the name check. So in the UK, we have well, in the world, we have a net zero policy, don't we, for global emissions. But I'm more interested in net zero intravenous prostacyclin. When do you think we will see no more intravenous prostacyclin being initiated in patients? We've got sotatercept, we've got some really fancy inhaled treprostinil now. 2030, do you think?
Yeah, probably difficult to come up with a date, but I'll tell you probably sooner for a lot of parts in the world who don't have a very well established parenteral therapy for PH because of all the logistics, all the complexity, and maybe the cost as well. So as a concept, probably it will take some time, but with the rapidity of the improvement in the understanding of the disease, the effective therapies, probably it will happen sooner. Patients will, even now, today, we are selecting other agents before we even consider parenteral therapy, although the guidelines are not very clear. So it's a matter of accumulating enough data for the guideline committees to be educated and change the guidelines.
Who believes in the room that no more intravenous prostacyclin will need to be initiated by 2030? Okay, I've got a few people with me.
So actually, that was my question to you, Luke. Would you stop using parenteral prostacyclin?
I think it's a real possibility that we won't need to initiate it in anybody after 2030.
Based on the current data. Okay. RD, please.
Just following the lines of my esteemed colleague, Luke, I think that we learned from the withdrawal study from the Hanover group that, in fact, when they are very efficaciously treated with sotatercept and other combinations of treatment, in some patients they could successfully wean the systemic prostanoids. They could even explant the implanted pumps that were given. But then again, we learned that in a subfraction of patients, they had to reintroduce the treatment. And personally, I believe that we still need this third pillar of treatment, which is the prostacyclins. But I agree with Luke that maybe in future, when we are, let's say, more ambitious, and when we have treated very efficaciously with the other complementary treatments, instead of completely withdrawing the prostacyclin pathway, we should think of a controlled transition to non-parenteral prostanoids inhaled and whatever we might have in future. So I think this is the way we should target.
But RD, before you, if you have another question, so let me comment on this. So wouldn't that be more appropriate? Because now we do know that really sotatercept has shown great efficacy in a group of patients, but not in all patients. Really, some patients, they have basically modest efficacy compared to some other patients where the drug is really magic. So again, going to these issues, do we know who are those ones whom we need to step down while adding sotatercept? I mean, is there a way to determine who is the patient who will benefit for sure from sotatercept so we can step down basically parenteral prostacyclin? Because clearly that, I'm sure in your experience and in our experience, some patient did magic with sotatercept, some patient had some modest effect. So how would you pick up those patients whom you say, I'm still going to go with the really parenteral prostacyclin because at least sotatercept might not be the magic drug in them, whom you think that I will probably not starting them on parenteral prostacyclin and I will start with sotatercept first?
Well, I think at the time being, we have no data that would support a first or even second line use of sotatercept. It is all, in third and fourth line because it's given in the majority of cases in patients who have at least a dual combination background therapy, and the majority of the patients that have been tested so far were even on a triple or even quadruple background therapy. So it's not yet ready for prime time to use it much earlier or even as first line. And then again, the clinical observation, at least with the many patients we have in our center, is as a rule of thumb, the rule of third. So we have a third so-called super responders who are either admitted at very critical stages. Some of them were ECMO dependent and could be weaned off ECMO by an early introduction of sotatercept. And also, of course, those prevalent patients that we learned from Stella and Pulsar. All of us, our centers, have those heavily pre-treated prevalent patients, again, amongst which a third are considered those that are really, really massively benefiting from it. Then there is about a third that has, okay-ish efficacy, but then again, balancing out long-term safety and efficacy, we have to have them under close supervision and then see when this balance is not working anymore. And then there is roughly a third that doesn't respond at all. And in those, when we observe the emergence of the side effects, because one thing is very homogeneous in all of these patients is the emergence of side effects over periods of time. The induction of an HHT phenotype is something that we've observed frequently. We should be courageous enough to, at certain stages, if they don't show hemodynamic response as we wish, and we know that this is what you don't get after half a year, you don't get after 2 years anymore. So then we should rather withdraw it and then give way to other complementary therapies. But overall, and I don't want to be mistaken, it's a marvelous drug. That's been what the community has been waiting for. It's a game changer for a fraction of the patients, a substantial fraction of the patients. It's life-saving for many patients, but it's not a one-size-fits-all drug.
I have a question for you, Dr. Yu. So you've shown us a lot of different molecules. So my question is, do we know about the distribution of expression of these molecules in the systemic vasculature as opposed to the pulmonary vasculature? Because we know, for example, the mammary arteries have different endothelial function compared to the coronaries. So this maybe help us anticipate side effects, for example.
That's a great question. You're absolutely right. So these ligands are, for the most part, not produced in the pulmonary circuit, but they're produced, in the case of BMP9 and BMP10, mainly in the liver and in some of the right atrial myocardium in the case of BMP10 as well. The activins are produced from probably bone marrow-derived cells, as well as tissue-resident professional macrophages. So they're not directly produced in the vasculature, and their effects are not exclusive to the pulmonary vasculature. So you hope that some of the toxicities, we have to be careful about our central vasculature as well as peripheral vasculature for the HHT effects that Artie just talked about. And there could be implications for other vascular disease, and it could be good or bad. So absolutely important, but it's hard to measure the tissue-specific concentrations of any of these things because they come from other sources.
Stephen?
Yeah, first of all, thanks to all of you. Beautiful talks. Also a question for Paul, and that relates to vascular homeostasis in general. So you presented on tyrosine kinases and then the TGF-beta and BMPs. And we know from sotatercept about side effects in the context of telangiectasia and others. So in the same concept, we have also potential issues with tyrosine kinase inhibition and vascular homeostasis. So my question is, can you speculate, or are you aware at the preclinical level of any potential additional safety concerns with telangiectasia disease if we think about tumor biology and vasculogenesis that could be a potential concern in the long term about tumor growth? And then with tyrosine kinases, we know that things like PDGF, PI3 kinase signaling is implicated in vascular integrity, also in the larger conductance vessels. So if we think about something like aortic aneurysms or something, it's pure speculation on one hand, but can you comment on that? Do we have any potential other safety issues with these pathways?
Absolutely. I think it's actually a minor miracle that something like sotatercept doesn't elicit some immediate adverse effects right from the start. It didn't reveal itself in any of the preclinical work because those are usually shorter studies. It took long-term observations in patients, and even our way of looking at the patients became more sensitive and sophisticated as we started understanding what those effects were. So you're absolutely right. These ligands are very important in aortopathy. Some of them are important in atherosclerosis. Some of them are important in vascular leak syndromes, similar to the ones that we see with anti-angiogenic therapy for cancer. We don't know if these agents will promote or inhibit cancer growth the way we've learned from our erythrocyte-stimulating therapies the hard way. So we have to be attentive to all these things. But I think in the end, it's going to be about designing the right strategy that circumscribes the key factors that are essential for your activity and hopefully selecting out the toxicity so that you can either get a sufficient margin of safety or even dose intermittently to treat your process if those pathways are so critical to homeostasis. And I think that's true for PDGFB as it is for activins and BMPs. Yeah.
Thank you.
Paul, if I may, there is compartmentalization at the tissue level and in the cell level. So I don't know, this makes things more complicated to predict what will happen in what organ, unless you start looking at it specifically for that implication. So the same genetic makeup of the cells will differ in response to these proteins and ligands versus other tissues. And inside the cell itself, maybe there is different components. And this is probably where the oncology research is going. Most of these drugs that, by the way, we talk about now, they are heavily looked at in the cancer research. So again, the issues, if you want to think about it as an isolated model, it will be very complex to really comprehend.
That's beautifully stated. I really can't add to that.
Okay, for the sake of the time, we're going to have one more question. Sonny, please.
Yeah. I have a question with regard to this LTI compound with the SMURF inhibitor. Because how selective is for the BMP receptor? Because is it more a proteasomal inhibitor you are trying to give, and giving 200-fold higher may give some results, but only BMPR2, neither from the animal models. It could be an initiator of the disease, but not. Is this really a therapeutic target?
Right. I mean, this is an enzyme that works, and probably there is 28 identified. And again, it is very heavily studied in the oncology research. So the idea is this is a general process in the proteins. You always worry about the side effects, what it will do. It will just decrease the readiness of the protein to be presented to the lysozymes, and it will probably degrade. The abnormality that was seen and noticed, there is overexpression of this particular SMURF. And the idea, if we block it, maybe we will restore the balance. But what will it do to other cells is not very clear. We don't have much data yet. And again, they are still in the early phase 1/2 because they wanted to still look into the proper dose. And of course, there will be some clinical trials into it. But the concept is intriguing if we are going to take the model of the cell and the same notion of the activins or the BMPs in general into the vasculature of the body. Assuming what I probably believe is true is that this will be very compartmentalized into the pulmonary circulation, not even to the heart or systemic circulation. But I might be completely wrong, and only data and basic science data will prove that.
Yeah, because maybe that is really important.
Correct.
Using a proteasomal inhibitor at such a high concentration.
Definitely.
Thank you.
Thank you so much. So now I'm going to call Professor Abdullah Dalan to come to the stage for the SAPH International Collaborating Society greeting.
Thank you, Paul. Great job. Thank you. It won't take 10 minutes. It also has been a tradition for SAPH to have our collaborating colleagues from international societies to greet the audience and to tell us about themselves as well as what they do in their country. It's going to be 2 to 3 minutes talk for each. So we'll start this year with our long-term collaborating society, BVRI, and Luke was assigned to deliver 2 minutes to 3 minutes talk about the BVRI and what they do and how they have been helping in the research in the field of pulmonary hypertension.
This microphone, yeah, it does work, yeah. Thank you. So I'm one of the co-leads of the IDDI, which is the Innovative Drug Discovery Initiative. I've been taking that role for the last couple of years with the PVRI. And so on behalf of the PVRI, I really appreciate the collaboration that we have with SAPH. So PVRI, if you don't know much about it, is a global organization that is really aiming to bring together PH physicians and patient associations throughout the world to deliver education and better care of PH throughout the world, improve access to therapies and so on. But there's also a very significant collaboration with industry as well in terms of drug discovery so from that perspective, there's an awful lot going on with PVRI that I would encourage people to look at. There are multiple task forces that people can get involved in, very keen to have all the range of people from very experienced, but all the way down to people who are rising stars in pulmonary hypertension to become involved in task forces where they can learn but also contribute, always looking for people who have got perhaps a bit more time on their hands than we have, who want to learn and who want to produce work. I think that one of the main products of PVRI is the international meeting, which happens roughly at the same time every year, about 2 weeks before this one. It's always in a fairly exotic location, so next year is in Bangkok. We've just come back from a somewhat less exotic location, well, at least to me, of Dublin. So 1 hour by plane. The weather wasn't exactly exotic either, although, interestingly, I have to put more clothes on when I visit Saudi than when I'm in Dublin, because your air conditioning is so strong. But I would say we know that the scientific meetings, the ATS and the ERS and some of the others have a lot of good quality pulmonary hypertension in there. But if there are 2 meetings that I would go to in the year to refresh myself in terms of the science and the clinical aspects, it would be SAPH and PVRI. And I think that the meeting that's really been developed over the last 19 years here is phenomenal. You really have got a fantastic meeting here, which is why PVRI is so pleased to still keep supporting that in terms of the education that's provided on a clinical and also scientific level, although we did get an overdose of basic science from Paul, as we heard. No, just kidding. So if you combine those 2 meetings, I think you get all you need in terms of your annual update. They do come right close to each other, and I noticed that next year, presumably because of Ramadan, it's brought forward.
Yes.
So you're having sympathy to us Westerners. So it's in January. So it'll be before Bangkok, but I'm still hoping to go to both. So please do look up PVRI. There's so much good stuff on there, and get involved.
Now let me present my colleague, Professor Fukumoto, who is the president of Japanese Pulmonary Circulation and Pulmonary Hypertension Society. Professor Fukumoto.
Thank you very much. I'm Yoshihiro Fukumoto, president of Japanese Pulmonary Circulation and Pulmonary Hypertension Society. I've been president for these 2 years, and this is my great honor to be here again. And this is a wonderful conference, actually. SAPH conference is very great. And I'm a cardiologist. I'm also a professor and chairman cardiology in Crimea University. And our Society of Pulmonary Hypertension had several events or topics last year in 2025. And actually, the major one was we have published guidelines for pulmonary hypertension and venous thromboembolism from our society and also Japanese Circulation Society in collaboration. But it was in Japanese version. And the second topic last year was that we were able to use sotatercept in clinical settings. So our therapeutic strategy has had a big difference compared with the previous ones. And this year, in 2026, we will have several events in our society. Actually, we are publishing English version of guidelines for pulmonary hypertension from Japanese Society of Cardiology and also our society too. And also we are making a textbook of a cardiac rehab in PAH and CTEF in Japanese version actually. Well, this textbook is written by, in our society, collaborated with the Japanese Cardiac Rehab Association. And actually, I'm also a president of a Japanese Cardiac Rehab Association. So the collaboration is very easy, actually. And we'd like to write an English version too. And if it's possible, we'd like to show you the cardiac rehab in PAH and CTEF in English version in near future. And we have an annual Congress of Pulmonary Hypertension in Japan too, but our Congress is only a Japanese version actually, and we try to extend international sessions. So if it's established, we'd like to invite all of you in near future. Thank you very much.
Thank you so much. And now it's my pleasure to introduce my colleague and friend, Professor Shi Hsin Su, President of Taiwan Society of Critical Care Medicine.
Thank you for inviting. It's my great honor to be here representing Taiwan in this world-famous pulmonary hypertension Congress. I would like to extend my deepest gratitude to organizing committee and our Saudis host for the warm hospitality and creating the vital platform for scientific exchange. In Taiwan, we have long admired the rapid advancement in healthcare infrastructure in Saudi Arabia. We have faced the complex challenge of pulmonary hypertension. Over the past decade, we have focused on establishing a multidisciplinary approach to pulmonary hypertension care. We have integrated advanced imaging, the genetic screen, and the pharmacotherapy to improve our patient outcome. But we know only technology is not enough. The true heart of the progression is rely on the cooperations. Learn from the patient unique demography and the clinical experience of our global partner. I think the Congress is a wonderful chance to share what we learned. We have yet to explore potential cooperations, including the clinical trial, registry data sharing, and the treatment strategy with you. Let us getting together. Let us using scaling to enhance to enhance our bridge between our medical community. Let's work together towards the early diagnosis, the more effective treatment, and offering the better quality of life and outcome for our patients. Thank you for warm welcomes. I look forward to the fruitful and inspiring program and the exchange of ideas. Shukran.
So that's it for tonight, and I think we had a very fruitful session, and it's time now for dinner. You are all invited to the dinner. It's by the pool. Just go right side at the end of the lobby, take the escalator down. Thank you so much. We'll see you in the morning.
Assalamu alaikum wa rahmatullahi wa barakatuh. On behalf of my colleagues and SAPH members, I welcome you to the 13th annual meeting.
Welcome to our 11th SAPH meeting. SAPH is the Saudi Association for Pulmonary Hypertension. It's a specialized group of elite physicians in Saudi Arabia and including some of the Gulf region.
Part of the Saudi Association for Pulmonary Hypertension meeting, SAPH2018, that was just held here in Dubai in April of 2018. It's been actually a great meeting. I've had a chance to interact with some of the leaders in the field.